Hello, Dr. Pritham. Hello, Dr. Pritham.
Hello.
Yeah, sir, I think Dr. Bharat is busy somewhere. He's not taking my call. So I think you please go ahead and start the quiz.
So are we connected to all the participants and the delegates
Yes, sir.
right now?
Yeah, we are connected, sir.
Okay. So they will be able to listen to my voice, but I will not be able to hear them, right?
Exactly, sir. Exactly.
Okay. So how do I know that they are ready and we are
So I
proceeding?
got messages. I got their messages that they are ready.
All right. Perfect. Fine. All right. Okay. Good evening, everybody. Myself, Dr. Pritam Kumar Jain, and Dr. Bharat Chauhan is busy somewhere. He was the one who was about to begin with the introduction, and currently he has handed over to me to begin with this session. So, welcome, friends, with this interesting session of Onco quiz. Let's enjoy this quiz sessions and something very interesting questions. Although I would like to say that I'm not an amateur quiz master, so I expect every one of you to kindly cooperate with my kind of quiz mastering if there is anything else, and expect a good response from you. So before I start with today's session, just would like to give certain instructions to all of you. So this is a quiz that will be comprising of 15 questions, right? And this 15 questions, each question I'm going to read out first, and then the timer will begin. And for each question, you will be getting 30 seconds to answer. After the 30 seconds, I will be, shifting it to the second question. So like this, the 15 questions will be over. You will be getting 30 seconds to answer to those questions. The answer to these questions and the winner of this session will be declared at the end of today's complete webinar session. So stay tuned, guys. A lot of questions will be coming from the same. Before I begin, Ravindra, can I have a confirmation that we've got maximum number of participants? Ravindra?
Hello.
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 Ravindra?
Yeah.
Before I begin this session, can I have a confirmation from your side that we've got a maximum participants right now?
Sure, sir. Just let me check. Yes, sir. So total 74 people are logged in on our portal, and they are seeing our quiz.
That's great. That's great, Ravindra.
All right, that's wonderful. So all of them have given confirmation that they are ready?
Yes, sir.
Perfect. So I'm going to count up to 3 and the first question will appear on the screen. So ready, steady, go. 1, 2, 3. Yes, Ravindra, can I have the first question? Okay, so here is the first question. Which of the following most accurately describes the overall incidence of driver mutations in advanced non-squamous non-small cell lung cancer with currently approved targeted therapies as of September 2020? A, 15%, B, 35%, C, 50%, D, 70%. Your time starts now.
The time's up.
Perfect. Can we go ahead with the next question? Identify the following images and give your final diagnosis. On the top of that, A, there is a skin redness infiltration. Then B, the skin biopsy shows some infiltrations. Number C, you can see an X-ray of the skull showing lytic lesions. Number D, you have on the blood, it is showing some flower-shaped cells. What is your final diagnosis?
Time's up, sir.
All right, let's move on to the next. When evaluating PDL1 22C3 IHC in non-small cell lung cancer, which of the following is considered positive? A. Membrane staining in tumor cells only. B. Any staining, cytoplasmic or membrane in tumor cells. C. Staining in the tumor cells and the inflammatory cells. D. Any staining in inflammatory cells only. E. Cytoplasmic staining in inflammatory cells only. Your time starts now.
Time's up.
Perfect. Let's move on to the next question. 62-year-old male presenting with acute onset of generalized lymphadenopathy, hepatomegaly, fever, B symptoms. On examination, patient had skin rash with lymphohistiocytic infiltrate. Also, patient had autoimmune phenomenon like polyarthritis, thyroid dysfunction, and hemolytic anemia. Laboratory study shows eosinophilia, polyclonal hyperglobulinemia, elevated LDH, anemia, and positive Coombs test. Bone marrow examination suggestive of marrow involved by lymphoma. What is your likely diagnosis? A. Anaplastic large cell lymphoma. B. Angioimmunoblastic lymphoma. C. Peripheral T cell lymphoma. D. Subcutaneous panniculitis like T cell lymphoma. Your time starts now.
Time's up.
Perfect. Okay, so the next question is, this patient was having a history of breast implant and followed by which patient developed breast pain, swelling and redness. And there was a fluid inside the swelling. The fluid was aspirated and the aspirated fluid showed large cells with round or pleomorphic cells with horseshoe shaped or embryoid shaped nuclei. What is your likely diagnosis? A. Peripheral T cell lymphoma. B. Angioimmunoblastic T cell lymphoma. C. Anaplastic large cell T cell lymphoma. D. Subcutaneous panniculitis T cell lymphoma. Your time starts right now. The image is showing kidney shaped nucleus or the horseshoe shaped nucleus.
So time's up.
All right, next question. 60-year male diagnosed as chronic myeloid leukemia and was on imatinib. After 2 years, patient developed imatinib resistance with increase in the BCR-ABL copies. Imatinib resistant mutational analysis studies detected E255KV mutation. Which of the following TKI drug is contraindicated in this mutation? A. Dasatinib, B. Nilotinib, C. Bosutinib, D. Ponatinib. We've got some exciting prizes. The first prize is going to get 5,000 rupees. Second prize, 3,000. Third prize, 2,500.
Time's up, sir.
Perfect. Next question. Which of the following is a moderate penetrance gene for breast cancer? A. BRCA1, B. PTEN, C. CHEK2, D. CDH1.
Time's up, sir.
Next question. Chomret criteria is developed to identify the patient with which gene mutation? A. P10, B. P53, C. Retinoblastoma, D. PI3K.
Time is up.
Next question. Who coined the term multiple myeloma? A. Kalers, B. Rustisky, C. Ellinger, D. Wright.
Time's up. Next slide.
Activating mutations in which of the following genes is seen in patients with hereditary papillary renal cell carcinoma? Apologies for the screen not showing that word. Activating mutations is seen in which of the following genes suffering from hereditary papillary renal cell carcinoma? A. VHL, B. MET, C. FLCN, D. SDHB. Patients with hereditary papillary renal cell carcinoma.
Next slide. Time's up.
Perfect. The next question, all of the following are founder mutations associated with individuals of Ashkenazi descent. A. 185 deletion AG, B. 5382 insertion C, C. 617 deletion T, D. 619 deletion. Founder mutations associated with Ashkenazi Jews.
Next slide. Time's up.
Next question, which of the following anti-RK alterations is predictive of response to TRK inhibitors? Fusions, B. Mutations, C. Amplifications, D. Fusions and mutations, E. Fusions, mutations and amplifications. The time starts right now.
Time's up.
Next question, low-dose CT scan screening has been shown to decrease the survival by A. 5%, B. 10%, C. 20%, D. 30%.
Time's up.
Next question, which of the following targeted agents is not a tyrosine kinase inhibitors that influences the HER family signaling pathway by binding to the intracellular domain of the receptors? A. Gefitinib, B. Erlotinib, C. Trastuzumab, D. Lapatinib.
Time's up.
Next question. Which of the following is not an alkyl inhibitor? A. Serotinib, B. Alectinib, C. Brigatinib, D. Ruxolitinib.
Time's up.
All right. Thank you. Thank you very much. So we have come to an end of today's first Onco quiz session. And the winners of these participants will be announced at the end of today's webinar session. So stay tuned, guys. Do not miss it. We've got exciting prizes. The first prize will be getting 5,000 rupees, second prize 3,000, and the third prize, will be getting 2,500. The winners of today's session will be eligible for the final rounds, which will be tomorrow. So we will be, calling out the winners of today's session by today's evening. Till then, I wish you all the best, and I hope you will enjoy the next session. One more important thing: a lot of questions will be coming from today's session. I know those who are going to attend today's session will be able to answer tomorrow's session quiz rounds. So thank you, Ravindra, and thank you, Dr. Bharat Chaun, for giving me this opportunity. And now I would like to call upon Dr. Bharat Chaun to take over this. Thank you.
Thank you, sir. Thanks for your time.
Thank you, Dr. Preetham, for a very nice quiz, and questions were really difficult. And now, without any delay, we should move forward for the next session. For next session, we have Padam Shri J.K. Singh sir. Really, we are blessed to have him. He's a senior most oncologist in the country, and Padam Shri plus sir has done a lot of work in the area of oncology, and he's a leading practitioner from Patna, Bihar. He has his own center and own hospital also. So welcome, sir. Thanks for gracing us.
Thank you. Thank you, Bharat. Thank you.
I also invite Dr. Nafis Siddiqui for gracing us as chairperson for the session. He's practicing in the area of Lucknow for past 15 years. He has done a lot of good work, and he's also very socially active and doing a lot of work. So welcome, Dr. Nafis. Dr. Nafis, are you there?
Yeah, Dr. Bro, thank you.
Yeah, so I think you, sir, and you both can take this session forward and invite the respective speakers and all.
Yeah, sir.
Yeah.
Hi, Nafis.
Hi, sir. How are you?
Fine. All well.
Sir, please proceed.
Friends, it's a nice time that we have joined this Onco update program. And I'm very much thankful to Bharat and Purohit for including me in this prestigious program. So, without wasting the time, breast is a heterogeneous disease with a variety of subtypes, each characterized by distinct pathological and molecular features. On the basis of molecular feature, it is now not difficult to determine the prognosis and recommend the treatment strategy. Now we will discuss about the different hormonal receptors and the treatment strategy in such cases. So right now we'll discuss about the hormonal receptor positive and HER2 negative advanced breast cancer. In such cases, hormone therapy is the main first-line treatment of choice, even alone or in combination with other agents. In the next few minutes, I'm sure we'll have a good discussions, and Dr. Preetham Kataria, a renowned oncologist, will enlighten us about how to pick up the right strategy for these subset of patients. So I will invite Dr. Preetham Kataria to start his presentation, please.
Yeah. Thank you for sir for the introduction, and I at the onset I thank Dr. Bharat Chauhan sir for giving me this opportunity. So I'm visible and audible, right?
Yeah, yeah.
Yeah. So I'll share my screen.
Yeah.
Yes, sir.
Yeah. Are my
Visible,
slides
sir.
visible?
Yeah. So
Yeah.
please put on full screen.
Yeah. Thank you. Yeah.
Perfect, sir.
Yeah. So the topic that has been given to me is picking the right strategy for hormone positive HER2 negative breast cancer with PI3KCA mutation, and this is something very exciting. So first we understand what is the importance of PI3K pathway in hormone positive breast cancer. What we know is that those patients who have a PI3K pathway activated, they are resistant to the hormone endocrine therapies that we are giving to the patients. About 40% of the hormone positive breast cancers have a PI3CA mutations, which lead to the hyperactivation of PI3K pathway. And these patients are resistant to the endocrine therapy. And so this path is very much important. So time and again, we have been thinking that luminal breast tumors are one of the good subset of the patients, but there is more to that. And that what we need to know is there are multiple mutations that are working at the background, and these are related or they are causing to the resistance to the treatment that we are offering to these patients. And the most common treatment that we are offering is AI and plus or minus CDK4/6 inhibitors. And so there's an unmet need for this hormone positive HER2 negative advanced breast cancers in such setting. So first line treatment, as I said, is always having a hormone therapy plus or minus inhibitors. And those patients who have acquired resistance to the endocrine therapy, the treatment remains a big challenge. And so in 40% of these patients, PIK3CA mutations, can be detected. And thanks to the the modern medicine, we have drug for this, and that is alpelisib. So this is a PIK3 class 1 family, and there are multiple drugs to that, but we are going to talk about alpelisib, which is a recommended drug for the treatment of the PIK3 mutated tumors in breast cancer. So as I said, 40% of the breast cancers have a PIK3 mutation at the outset, and they have a prognostic value. So PIK3 mutation are related to cell proliferation, tumorigenesis, poor prognosis, and endocrine therapy resistance in these patients. And alpelisib is a specific inhibitor of PI3K alpha, and this PI3K alpha is related to the and alpelisib is been found in the various xenograft models and now in the human studies being a inhibitor of PI3K alpha. So in the phase 1b trial of the alpelisib plus fulvestrant, what we knew is these patients in a phase 1b study also had a good PFS benefit of 9.5 months versus 5.7 months. And this led to a further study of that is the SOLAR study, which was a phase 3 randomized control trial. And it looked at both men and postmenopausal females who had a previous AI therapy, and the PIK3 mutation status was done on archival of fresh specimen. And they had taken those patients who had a PIK3 mutated subset, and they also included those patients who were PIK3 non-mutated. So these were the two groups, and alpelisib was added to the previous group, as well as in the non-mutated group they had added alpelisib. And so the inclusion criteria was prior exposure to the aromatase inhibitor, and these patients were enrolled in this trial. And what we know is, if we look at this, the graph, the table, what we can understand is the adverse events were more in those patients who were PIK3 non-mutated. Also, if you look at the follow-up study, what we know is the follow-up of those patients who harbored the PIK3 mutation was around 25 months, while in those patients who were non-PIK3 mutated, the follow-up was very short. As we understand that those patients who are non-PIK3 mutated, this drug doesn't work really better in these patients. And in those patients who were PIK3 mutated, there was almost doubling of the progression-free survival, 11 months versus 5.7 months. And if we look at the forest chart, what we can understand is in all the subset, irrespective of the site of metastasis, irrespective of the previous chemotherapy received, irrespective of the endocrine status, whether they were sensitive, resistant, and the different mutation subtypes in PIK3CA, alpelisib did better as compared to placebo. And if you look at the overall response rate, what we can understand is more than the doubling of the overall response rate, 35.7% versus 16.2%. Also, when it was looked at whether the same PFS was seen in those patients where the PIK3 mutation was designated by using a tissue sample or a plasma circulating DNA, it was said that the PFS was maintained in both type of specimen where the PIK3 mutation was carried out. If we look at the adverse event, what we know is the hyperglycemia was a major deterrent for using this drug. The grade 3, grade 4 was around 35 to 36% and overall 64%, which is an important side effect that needs to be really addressed to. And the second was diarrhea, and rash was the other one, which was of significant importance. And if we look at how to manage hyperglycemia, those patients who had a grade 3, grade 4 had to be required the drug stoppage, followed by reduction of the drugs, the dosage of the drug, so that also we need to involve the diabetologist, and anti-diabetic medications needs to be started initially with metformin, and if the control is not better, we need to add insulin in these patients. Also, those patients who had a rash and were given prophylactically antihistaminics, those patients had lesser rash incidence as compared to those patients who didn't receive a prophylactic antihistaminic. Also, topical corticosteroids is one of the ways by which we can counter this rash. Now, this is the chart looking at the management of the different side effects related to alpelisib, and like hypertension, hyperglycemia, rash, so on and so forth. Now, this was the second good study, which is a BILIEVE study, which looked at those patients who were treated with alpelisib plus fulvestrant in those who were previously been treated with CDK4/6 inhibitor. Mind you, in the SOLAR-1 study, there were a few patients who were treated with CDK4/6 inhibitors also. And this was a specific study which the inclusion criteria included previous treatment with CDK4/6 inhibitor. It was a phase 2 study, and what we can see is all the patients with respect to the endocrine resistance were included. And the primary endpoint of this study was how many patients were alive at the end of 6 months. So the PFS at 6 months was very much important. And what we can find is that 50% of the patients were alive without progressive disease at the end of 6 months. If we look at the SOLAR trial, what we can find is at the end of 6 months, 45% patients were alive or without progressive disease at the end of 6 months. So, reiterating the fact that in those patients where CDK4/6 inhibitors have been used previously, alpelisib will do wonders. And these patients are, this is a subset where we would be more inclined to find out that the PIK3 mutation is existing. And if we look at the response rate, impressive one. And if we look at the side effects, again, which holds true in the SOLAR-1 study, also were resonated in this particular study also. So in this BILIEVE study, the conclusion was the primary endpoint, 50% patients were alive without progressive disease at the end of 6 months, and the median PFS was around 7 to 8 months. So the key takeaways, 40% of the patients have a PIK3 mutation. Alpelisib improved the PFS and the overall response rate. Almost doubling of the PFS and overall response rate was seen. Also, it is only first investigational PIK3 inhibitor which showed a superior PFS advantage with manageable toxicities, and alpelisib also shows benefit in those patients who has been previously been treated with CDK4/6 inhibitors. So this is an important drug into our armamentarium where where we are more concerned with the endocrine resistance. Thank you.
Thank you, Dr. Preetham. It was such a very, very nice presentation. And I think it was very much beneficial for us also. Since we have the panel discussion just after that, I think question and answers we can take up after this panel discussion. So I will request Dr. Nafis Siddiqui to take up the matter and introduce the moderator and panelists to all the participants, please. Dr. Siddiqui, please. Dr. Siddiqui, please.
Sir, I guess he has some problem in internet, so he may left the Zoom platform. So I think you proceed, sir.
Okay. So for this, this is a very interesting case-based panel discussion, and this is about journey from dream to reality in HR positive and HER2 negative advanced breast cancer. It will be moderated by Dr. C.V. Pethe, and the panelist will be Dr. Amit Ranekar, Dr. Sandeep Vipil, and Dr. Vijay Sarnagat, and Dr. Avinash Telek. So I'll request the moderator to start the presentation.
Thank you so much, sir, for those kind words. Now, I'm Dr. Chandrasekhar Pethe. I'm a medical oncologist practicing in Nashik for a long time now, and I've been here for the last 10 months. And I've been really fortunate to have great stalwarts in my panel with Avinash, Dr. Sandeep, and Dr. Amit here with me. Just to start off with my panel discussion, let me introduce the topic. I hope my slides are visible and I'm clearly audible. We did not have electricity here since early morning. Fortunately, the electricity has just come back so that I can turn on my broadband. As you all know, for a long time. Hello?
It's perfectly visible. You are audible clearly.
Thank you so much. Now, as you all know, we have been this metastatic breast cancer topic is being discussed for a very long time, say for the last 20, 25, 30 years, wherein we had more and more drugs come into picture, but it is only since the endocrine therapy with anastrozole inhibitors that the overall survival started improving. Till then, but then unfortunately, till now, we have had an improvement in overall survival by less than 5%. And that is what makes the topic that we have today a little more interesting. Let me begin with a case. I have a 63-year-old female, postmenopausal, ECOG1. She had a nodule in the right breast. Core biopsy revealed a hormone receptor positive, HER2 negative, invasive ductal carcinoma. She underwent partial mastectomy, radiation, and adjuvant AI therapy for 5 years. After 5 years of completion of this aromatase inhibitor therapy, she developed pain in the right clavicle, which was unresolved with NSAIDs. That is how she underwent a scan, which revealed a lesion in the right clavicle. And then a bone scan confirmed an extensive bone metastasis. And the PET scan revealed that the bone restricted disease, that she has got a bone restricted disease. So how will we approach? Avinash, will you be kind enough to take this first question? Could you just suggest what is the role of rebiopsy in this patient who has failed after 5 years of completion of aromatase inhibitor therapy? Hello? Hello? Do you have Avinash here? Amit, can you take this question, please?
Yeah, I mean, here we would not really think of biopsy because the picture looks like a hormone receptor positive breast cancer biology, but then taken it in parts up to 15-20%, we know that there is a change of receptor status. So ideally, I would offer biopsy, but in real life, I would start on second line of hormonal therapy and then strongly consider biopsy if the response is not seen.
Right. So,
Hello?
Hello? Yes.
Yeah, am I audible?
Yes, Amit, you are perfectly audible.
Yeah.
So as you rightly put out, the history strongly goes in favor of possibly a still hormone receptor positive disease. So we may skip biopsy and then straight away go ahead and offer the patient some kind of hormone therapy depending on whatever is our approach. Now that is the real point of our discussion today. Now this question pops up because now we have got more and more treatment options coming into picture. More treatment options gives rise to more confusion of selection of drugs. Which brings us to the next topic. Now, way back when we had, when I was doing my DM, say around 10 years back, the choice was very obvious. Just put on tamoxifen and forget it, or just put on letrozole and forget it, because these were only two drugs that were available at that point of time. At that point of time, it was said that fulvestrant is not a good drug because the dose that was used was probably incorrect. So most of us used to say that fulvestrant is not a good drug when compared to, say, aromatase inhibitors. So if a patient has been on tamoxifen, just put the patient on letrozole. If the patient has been on letrozole, let's put the patient on tamoxifen. So now, Amit, what would you suggest? If you want to add hormone therapy, what would be your drug of choice? Fulvestrant or aromatase inhibitor? Or you would still like to go ahead with tamoxifen?
Just to interrupt the first slide, I missed it. Some error in the connection. So when was the adjuvant therapy completed of this lady?
This lady completed adjuvant therapy 5 years back, meaning that for last 5 years, she has not been on any kind of treatment.
And she's a menopausal lady, extensively bone metastatic.
Yes. Oh, bone only metastasis. I would rather put it blunt ahead.
Yeah, I would prefer.
Amit, just to interrupt for a minute, can you just give me a second, please? Yes, sorry, I'm back. Yes, Amit, I'm back.
So her adjuvant therapy has been,
Amit, I can't hear you.
Hello.
Amit, I can't hear you.
Hello.
Yes.
Yeah, I mean, here I would obviously go ahead with either fulvestrant or even an AI, and I would talk to them about a CDK4 inhibitor upfront.
Let's come to the topic of CDK4 inhibitor sometime later. But then here I just want to discuss some science because I prefer to go back into history and treat. Fulvestrant, AI.
AI.
Okay, perfect. Dr. Sandeep, what is your opinion here? Fulvestrant, AI.
Yeah, I think the AI would be the better option.
And why so? We had some literature to suggest that being an estrogen receptor down regulator, probably fulvestrant is a better drug.
Okay.
Hello.
Hello.
Yes, Dr. Sandeep.
Yeah.
Dr. Vijay speaking. So
yes, Vijay.
I think we should go ahead with like fulvestrant according to the Falcon trials. So the progression-free survival which was seen with the fulvestrant is better than AI. So I think the fulvestrant is the best option for a lady considering the bone mets and hormone positive disease initially.
Could you put a number to it? What was the improvement, AI versus fulvestrant?
Yeah. So progression-free survival, if you see in the terms of months, for like bone-only disease, and there was no like liver mets, lung mets. It was like 23 months versus like 15 months for fulvestrant against aromatase inhibitor.
Perfect. Now that brings me to one more interesting topic. If you look at the NCCN guidelines, say 3 years back, we had an option of using, if I just enumerate it according to the serial that they have given, if a patient can, in our setup, if a patient can afford CDK4/6 inhibitor, probably we had got two options in NCCN guidelines, say 3 or 4 years back. One was using fulvestrant alone, and second was using palbociclib plus letrozole. That was what was given in that particular guideline. More so because ribociclib at that point in time was not available in India, and the trial of ribociclib plus fulvestrant giving rise to a better overall survival as compared to fulvestrant alone was not available at that point in time. So probably if I go back to history, 3 years back, I had an option of using fulvestrant alone if a patient, as modified by the economics, if the patient did not afford palbociclib, probably my first line of therapy would have been fulvestrant and not AI at that point in time. But then, as Amit rightly put it, we have got many more advantages of aromatase inhibitor in the form of that it's an extremely cheap drug, gives rise to a good OS, gives rise to a good PFS. 10 months, 12 months is fair enough for a patient with metastatic disease. So if you go back into history, probably AI versus fulvestrant would not have mattered. 3 years back, fulvestrant mattered. And as Vijay rightly put it, probably as of now, if I'm not planning to put a patient on CDK4/6 inhibitor, probably fulvestrant would be a good drug to use if used as a single agent. Now, Dr. Sandeep, can you elaborate on the role of CDK4/6 inhibitor in this particular scenario, wherein I have not yet selected what could be the partner with CDK4/6 inhibitor. Point number, I have not yet selected whether it is going to be AI/fulvestrant/tamoxifen. And now we have got new drug that Preetham presented of the role of alpelisib coming into picture for those patients who fail on CDK4/6 inhibitor, wherein we have got a trial of only using fulvestrant plus alpelisib. Could you please elaborate on this? If this patient comes to you today with a failed
With the
disease,
recent data, what we available. Okay, so I think with the recent available data, the CDK4/6 inhibitors are good option to use often in metastatic setting.
Okay, what would be your preferred drug? Ribociclib/palbociclib/abemaciclib?
So to start with, I think the newer one, the ribociclib one, the best option in survival, the overall survival.
Okay, Vijay, what would be your take on this?
Yeah, so considering the CDK4/6 inhibitors, so I think amongst the three which right now we have, so if you see the data, so there will not be any difference in the progression-free survivals maybe amongst all these three. So the difference is only like in terms of toxicity profile. So whenever we want to choose, we need to see that. So recently, if you see the overall survival data has come with like ribociclib. So sometimes maybe because of that overall survival data, so I'm like more inclined for ribociclib. The partner drugs, if you are asking me about the partner drugs, so I would like to know regarding
No,
the therapy.
Vijay, you are
told me that
Vijay, just to interrupt you, you are running ahead of me. I would just like you to comment on what CDK4/6 inhibitor would you like?
CD4. Yeah, that's done.
Okay, so you would prefer ribociclib?
Yes.
Yes, mainly based on data that it probably gives us a better
survival data.
overall survival. Yes. Okay, thank you. Amit,
Avinash, I have to make a comment.
Avinash, I'm so happy that you are back.
Sorry, sir. There was an issue and I was not audible then.
No,
sir. I would prefer ribociclib for two reasons. Because we have a mature data that it is the only CDK4/6 inhibitor that has demonstrated overall survival benefit, number one. And it is the only one which is indicated in pre and post menopausal, both of the age groups.
Okay.
And thirdly, that the fatigue which was there, which one of the first CDK4/6 which came, which was very difficult to treat. Fatigue was the main side effect that I had, the challenge that I and my patients face. So, and I'm much comfortable using the ribociclib, and so because of that, I would switch more towards the ribociclib than its previous CDK4/6.
Okay, Amit, I saw you smiling. Do you have any comment on ribociclib versus palbociclib? I'm not very fond of abemaciclib because I've never used it till now.
There is an OS benefit, so ribociclib would be preferred. And also, I would like to add that the rate of responses are faster. And somebody who is having a lot of bone metastasis, you are with the worry of fractures. I even prime my patients to take care not to fall, because if that happens, your quality of life takes a backseat. Ribociclib responses are much faster, so that would be an add-on point in favor of ribociclib.
So most of the patients who do respond within, say, first 9 to 12 weeks. That is what the data tells us.
8 weeks onward, you start seeing significant.
Perfect. Dr. Sandeep, would the comorbid features help you distinguish between would you use ribo versus palbo?
I think the overall safety profile with the ribo is much more better with the ribociclib.
Okay, let me give you a small a case presentation here, that this patient has a pre-existent left bundle branch block, fairly common in an elderly lady. Palbo, Ribo?
Sir, in this, Avinash, can I speak?
Yes,
Sir?
Avinash, please stay.
Yes, yes. Sir, in this case, I would be tempted to use more of a palbociclib
Mhm.
because there is a concern of increased QT interval with
Mhm.
the ribociclib drug, and we do need to monitor them with an ECG for first after at baseline and then 2 weeks after starting the ribociclib,
Mhm.
and subsequently like monthly and 3 monthly.
Mhm.
So if this issue is there, then I would switch to palbociclib. Otherwise, I would go with ribociclib if this
Okay.
comorbidity is not there.
Perfect, perfect. Vijay, does the tablet
Yeah.
strength really affect your selection of Ribo versus Palbo?
Really not, but it is more convenient to give like ribociclib because it comes like 200 milligram. We can give 3 tablets. Dose adjustment is very very convenient. Whenever we want to like reduce dose, yeah, exactly we can come like down by 200 milligram. So yeah, it's better to start with I think ribociclib, and dosage adjustment is I think it's better with that.
Perfect. So probably the dose adjustment of Ribo is better than, or it's rather simpler with Palbo, because you
Yeah,
need to
simpler.
throw away
Yes.
those 125 mg tablet if the patient does not really tolerate it. Fair enough.
Yeah.
Amit, any more take on this Ribo versus Palbo?
Yeah, if the heart issue is not there, I would still bank on ribociclib. Faster
Okay.
response rates, OS benefit, and otherwise a very peaceful tablet.
Okay. And would the cost guide you in this particular selection?
Both are more or less costly right now.
Still, then there is a difference of nearly 30,000 rupees, if I'm not wrong, for a month of therapy.
No, it is some 60 and 80 with some schemes. So eventually, somebody who is shelling out that much of money for a month, I make a point to convince them that this difference should not matter.
So patient who can spend 60,000 can easily end up spending 80,000 also. Fair enough, not an option, because these are points that are being normally put in front of us when people do visit us for a visit, and these are the points that are brought up in our discussion. Fair
Actually,
enough.
Palco comes somewhere around 80 and this comes somewhere around 60. Both of them have some, health programs 8 and 10 months down the line. And most of the patients have crossed it.
Okay. Even almost three of my patients are on support programs for last 3 years now. Fair enough.
Why is this?
So now brings us to the third more interesting point: is what combination would you prefer to use? Avinash, can you take this question? So just to cut short on discussion, we have got 10 minutes left. Point number one is point number one is fulvestrant, which we have already discarded because as a single agent, before the ribociclib trial came into picture, fulvestrant would probably have been the drug of choice. Let us keep it to one side as of now. So now we have got multiple permutations and combinations here: fulvestrant plus palbociclib, fulvestrant plus ribociclib. We have got aromatase inhibitor plus ribociclib, and then we have got say one more option of your choice, say tamoxifen plus ribociclib if the patient is premenopausal. So what would you use?
Sir, depending upon what line of therapy we are starting, de novo metastatic, first line I would go with postmenopausal, I would go with aromatase inhibitor and ribociclib. And okay, and second line postmenopausal, it is fulvestrant plus ribociclib. In premenopausal, ovarian suppression plus ribociclib.
Okay. But then Avinash, we did have some data which suggested that fulvestrant plus ribociclib is better than letrozole plus ribociclib.
Yes, sir. We do have a data that there the PFS was around 24 months. Where in fulvestrant in Mona Lisa, I think Mona Lisa 7. I'm not really sure. So yes, that is definitely there, and I agree with your point. But what here is in what line we add them up. If somebody's already taken aromatase inhibitor, then we are left with fulvestrant with ribociclib.
But in this particular case scenario that we are discussing, the patient has been off treatment for 5 years, so she's as good as a de novo metastatic disease.
She's a de novo metastatic disease, so here the best option for her would be fulvestrant plus ribociclib.
Fulvestrant plus ribociclib. Perfect. Amit, what would be your take here?
Yeah, I would agree. Just extrapolating, if there is a possibility that PI3K would be, affordable, then I would be tempted to discuss about AI with ribociclib.
Okay, so you would, depending on the Alpelsip data that Pritam was so nice to present, we would probably keep one more drug in our hand. Perfect, fair enough.
Because this is a hormone receptor positive disease, bone confined disease, metastasis, visceral not involved. So this is going to be a long match.
Perfect, perfect. Vijay, what would be your take? fulvestrant plus ribociclib versus. Yes, Vijay.
Agree with Avinash. So can we consider this partner drug as fulvestrant? But I would like to know regarding the initial therapy. So as you told that lady has taken letrozole for 5 years, but when she developed metastasis, so what was the duration between that to
5 years?
like
5
end
years.
of the
She has been 5 years off treatment.
Off treatment, right?
Yes.
So if she has been off treatment for 5 years after last treatment like letrozole, so I would consider to go ahead with like AI plus CDK4 inhibitor like ribociclib, AI plus. So yeah, this is my preference.
Okay. Just because you have alpelisib coming into picture now?
No, that is not thing.
Okay.
So the trials which have conducted, so they have used like partner drugs whenever the last like endocrine therapy which was given. So whenever it was like after completion of the treatment, there is progression within like 12 months or later on after 12 months. So that is considered. Whenever progression happens, like within 12 months of end of endocrine therapy, then we should consider fulvestrant as partner drug. If this progression happens like after 12 months of completion of endocrine therapy, then we can reconsider this type of AI. So that is the thing.
Okay. So now just taking your point forward, this is a snapshot of the few trials that we have. Dr. Sandeep, do you have any point to comment on Mona Lisa 7 versus 3 versus 2? What would be your preferred drug?
In the ribo in the same patient, but already had the letrozole.
Yes. Letrozole was done 5 years back, so we have got a fairly long PFS, which normally happens in a hormone receptor positive patient.
I think again we have good option to have the ribo with the AI. We can use this.
Okay. So just to summarize whatever we have discussed till now, we have got multiple treatment options for a first-line metastatic disease. We have got AI, we have got fulvestrant. So if I'm using single agent, probably my own choice would be using fulvestrant as a single agent than AI, just because I've got a better data with single agent fulvestrant. If a patient can and really does afford CDK4/6 inhibitor, ribociclib, palbociclib, as of now, these are the two things in our hands. Ribociclib probably scores over palbociclib because we have got overall survival data that has been presented with ribo, which has not been presented with palbociclib. But then things do change, and then next year we might have some entirely different data as of now. So for first-line metastatic setting, probably my drug of choice will be fulvestrant plus ribociclib because I have got a stronger data with ribociclib plus fulvestrant. But then, as somebody like say Amit and Preetham probably pointed out in their presentations, is that we probably, because now a third drug is coming to picture with alpelisib, which has gotten approval only with the use of fulvestrant. And if I use fulvestrant, I may not be able to use it with alpelisib if I have to use that particular selection criteria. So probably ribociclib plus AI might still remain the drug of choice, though I would not be very comfortable using it because the data with fulvestrant is much stronger than with other inhibitors. Thank you so much. I had got an excellent panel with me. I tried to cut it short just to fit in your time. I think we started off late. I finished off 5 minutes early. We are open to suggestions and comments from all my panelists.
Yeah, just one a tangential question. I would like everybody to sort of give their opinions. Now, with in the spectrum of HR positive, do we still see a segment for mTOR inhibitors?
That is one question that I wanted to ask, but then I thought I would better finish on time because see, if you go into the details of whatever has been presented till now, the trial which I think the Bolero 2 trial, which actually brought mTOR inhibitors into picture, had extremely wide selection criteria as compared to the alpelisib trial. So if you ask me, till I have got such an excellent trial coming off with alpelisib, as I said, my drug of choice would probably be fulvestrant plus ribociclib, and then probably I will go on to add mTOR inhibitor instead of using alpelisib. Till the data with alpelisib with some other drug is proven to be better than with say exemestane plus
yes.
everolimus. But then I think it is open to discussion.
अच्छा 7 बजे के बाद कॉल करना.
Avinash, your take on this? Excellent question by Amit.
Yes, sir. And sir, also my, because the what I have been facing is I have never been able to use the full dose with mTOR inhibitor in my practice. The mucositis has been very challenging, and with so I would keep it definitely down the line. Somebody who just cannot afford these things, only them I would offer this because we have a very good survival data, and in fact these CDK4/6 inhibitors in ABC4 guidelines, we know that they can even be used in visceral crisis in hormone positive patients. So they are, I would always prefer the CDK4/6 over mTOR inhibitors.
Vijay, your take on this?
Yeah, so I prefer this type of I prefer examination and like everolimus or everolimus maybe combination with like fulvestrant or aromatase inhibitor, maybe like after fulvestrant or after CDK4/6 inhibitor only. Yeah.
Amit, just to stretch your question, I found I have got 2 or 3 patients on alpelisib as of now, and I think I find mTOR inhibitor to be a much safer drug to use. But then I think this is too small an experience. I think we'll as we progress, we'll have more comfort with using different drugs. I thank Bharat Sawan for letting me for giving me this opportunity of being here with this excellent faculty. Back to the organizers. Thank you so much.
It was pleasure
think
having you, sir. Yeah.
Thank you.
I think it's a very good. Thank you. It's a very good discussion, and I really thank to moderator Dr. Chandrasekhar and all the panelists, Dr. Amit, Dr. Sandeep, Dr. Vijay, Dr. Avinash, for nicely conducting the entire panel discussions and making it a program a great success. With this, we conclude this panel discussions and this session also. And over to Dr. Bharat.
Thank you, sir.
Thank you, sir. A very good discussion. Ravindra, anything you want to say? Ravindra?
So we have total 117 attendees, delegates who are watching us on our different platform. So total 117 delegates are there. Logins we have received till now.
That's great. That's great.
That's
Now,
great. That's great.
yeah, we'll move on to the next session. Dr. Kushal Gupta will take over now. Dr. Kushal, are you there?
Yeah, yes, I am there. Thank you, sir, for inviting me to be session coordinator for this lung cancer session. So we are pleased to invite Dr. Ramesh Bilimaga. So he is the professor and director of HCG Bangalore, and he is also the professor of radiotherapy at MS Ramaiah Medical College. He is a well-known face in the field of radiation oncology, having been trained in Norfolk Medical School, Long Beach Medical School, and Mount Sinai. And he has more than 40 years of research experience in IGRT, IMRT, and CyberKnife. And his areas of interest include head and neck cancer, breast and cervix cancer. And he's also the founder of the Indian College of Radiation Oncology. A very warm welcome to you, sir.
Oh, thank you, Vishal. In fact, we had a very good the breast session. Generally, the breast session is the one which very difficult to finish it in in the stipulated time. I really congratulate the session, the chairperson and the speaker and the moderator. Now we are switching our gear to the lung cancer, and this session has one speaker and one panel discussion stretching over 60 minutes, and let's also try to maintain our timing. And may I call upon the first speaker is Dr. Advait Gaur. You are there, na? Advait?
Yes, sir, I'm here.
You are very good, very good. You are welcome. And the topic is on evolution of TKIs and current treatment outcomes in first line EGFR in NSC-HC. Can I request him to go ahead?
Sure, sir. Thank you.
Yeah, please.
Thank you, Bharat, for getting all of us here for such an interactive discussion. I love speaking on this forum because all of us are grown together and we've seen many of these treatments develop right from our residency till the time we are now. So what I'm going to give an overview over next 15-20 minutes is how do we actually look at the EGFR TKI development and selection of first line therapy and will share data on osimertinib. We know that in terms of incidence as well as mortality, lung cancer is the number one cause of new cancer cases and cancer deaths worldwide. When we look in about lung cancer in India, it's the fourth common overall. This is as per the Globocon data of the 2018. I'm sure this has increased, and it's the second most common cancer in males, with a male to female predominance ratio of about 4.5. And as the natural history is, it's more common in smokers as related to non-smokers. We've been through a transition wherein the treatment for stage 4 lung cancer was supportive care only about 20 to 25 years back, up to the time that EGFR positive lung cancer patients, about 15% of them are surviving for 5 years or beyond. When we come to specifically in terms of EGFR positive lung cancer, we know that the non-small cell lung cancer is divided into a completely molecular level classification, where based on the molecular or PDL1 testing in our day-to-day practice, we do segregate these patients into those non-small cell lung cancers having EGFR sensitizing mutation, those with ALK, ROS1, BRAF, MET, HER2, and PDL1 expression also. Today our focus is going to be only on the EGFR mutation positive patients, wherein we have 3 generations of drugs at our disposal to be used as monotherapy. The first generation ones, which is the erlotinib and geftinib, which are the reversible inhibitors. The second generation ones, the afatinib and dacometinib, which are irreversible inhibitors. And the third generation drug, which is osimertinib, which initially came in as a second line treatment for patients who had received first or second generation EGFR TKIs, especially those harboring T790M mutation, and then has moved into first line. There is also data coming up on combining these EGFR inhibitors along with VEGF inhibitors. There is data for using erlotinib with bevacizumab and erlotinib along with ramucirumab as a first line therapy. And there is also data on using combination of EGFR inhibitor along with chemotherapy as a first line treatment. So in terms of EGFR mutation positive, this is what the NCCN guideline version 4.20 mentions, that if a mutation is discovered prior to initiating first line systemic therapy, then osimertinib should be the preferred option. The other recommended category 1 options still continue to have erlotinib, afatinib, geftinib, dacometinib, and erlotinib with ramucirumab as category 1 indications. As we were discussing about various generations of TKI, I mentioned that the first generation ones are reversible, have reversible binding to wild type and mutant EGFR, and as the generations increases to second and third generation, it does cover broader activity to overcome EGFR TKI resistant clones also. Osimertinib, which is a third generation TKI, specifically works for EGFR T790 mutant, and this also has an irreversible binding to the EGFR kinase domain. When we reviewed the literature of what these drugs have shown in the past, we have the IPAS study, which was on geftinib versus paclitaxel carboplatin. Now this study has been done and published about more than 10 years back, where giving standard platinum doublet was the standard of care for all NSCLC patients. IPAS study looked into stage 3, stage 4 NSCLC patients, and patients were randomized to geftinib 250 milligram daily versus paclitaxel and carboplatin. And this was an exploratory analysis for biomarkers in terms of EGFR mutation, gene copy number, and protein expression. And in this EGFR positive patients, it did show that there was a progression-free survival benefit by using geftinib in this group of population of patients as compared to giving chemotherapy, with a significant p-value and a hazard ratio of 0.74. When we look at by mutation status in the EGFR mutations positive subgroup, which are the graph on your left, the PFS was significantly longer in patients receiving geftinib, while in the EGFR mutation negative subgroup, the PFS was actually shorter in geftinib treated patient, thus confirming the proof of principle that these drugs are going to work only in EGFR positive mutation patients. However, this trial was disappointing because we did not really get any overall survival benefit. Possibly it was related to the way the study was designed, that these patients were eventually asked to cross over, and we see a median overall survival between the two arms absolutely same. There are multiple phase 3 trials of erlotinib and afatinib which were performed. For erlotinib, we have these three landmark studies, the EUROTAC, the INSURE, and the OPTIMAL, and the afatinib studies are the LUX-Lung 3 and LUX-Lung 6. Looking at the erlotinib data, that all the three trials also showed that there was improvement in the PFS, but there was no improvement in overall survival, but there was improvement in quality of life. Looking at the LUX-Lung 3 and the LUX-Lung 6, when we look at the PFS curves of these studies, the one on the left is the LUX-Lung 3, right is the LUX-Lung 6. We get to see that there is a PFS benefit at median follow-up of about 16.5 months in favor of afatinib with a hazard ratio of 0.58. When we look at overall survival, again, we see that there isn't much to choose from because overall survival remains the same. The PFS curves for the LUX-Lung 7, which actually enrolled patients who were EGFR positive to receive either afatinib, which was a second generation TKI, versus gefitinib in first line setting, showed that both afatinib or gefitinib showed that there was a PFS, median PFS of about 11 months. Stable disease and overall response rate were almost similar in both the studies. When we look at the dacomitinib data, Archer 1050 trial looked at advanced NSCLC patients who were EGFR positive, but all these patients were without CNS metastasis, randomized 1:1 to dacomitinib versus gefitinib, and they were stratified based on the EGFR mutation type as well as the race. And the results showed that the PFS and OS were superior with dacomitinib versus gefitinib, and PFS showing a median PFS of 14.7 for dacomitinib versus 9.2 months for gefitinib, and an overall survival of 34 months with dacomitinib versus 26 months with gefitinib. No brain metastasis patients were, however, included in this study, and patients who have brain metastasis, we know that the EGFR positive NSCLC having brain metastasis do have a bad clinical outcome. When we look at the PFS by independent review or the blinded evaluation, the median PFS did favor dacomitinib. Overall survival, however, we see that the overall survival was slightly better than dacomitinib, but it's so difficult to interpret because the number of patients who are going beyond 42 months is actually so very small that we can't really make an inference. Also, we see that the curves are actually turning around and overlapping roughly at around 12-month mark, that the dacomitinib becomes better than gefitinib. So overall survival was also not statistically significant. So far we've seen that with this first and second generation agents, we get a good overall response, we get a good median PFS, but not a really significant median overall survival. When we look at the tolerability and safety profile of these EGFR TKIs, we know that across the board, about 30 to 45% patients do experience grade 3 or more adverse events, and about 10 to 15% patients may have to discontinue the therapy because of these adverse events. So, in summary, for the first and the second generation TKI, none of these have actually shown an overall survival benefit, and there definitely is an increased toxicity with the second generation TKIs as compared to the first generation TKIs. And we get a median PFS with either of these agents somewhere between 11 months to 14 months. Now, touching on the FLORA data, FLORA was a double-blinded study which looked at EGFR mutation status and ethnicity, whether Asian or non-Asian, in stage 4 NSCLC patients, patients who were having CNS metastasis, who have been pre-treated with stable CNS metastasis were allowed, and these patients were randomized either to a first-generation TKI, erlotinib or gefitinib versus osimertinib. We look at the baseline characters and they appear to be very well matched. The primary analysis in terms of progression-free survival did show that there was a median PFS of 18.9 months with osimertinib as compared to 10 months with the comparator first generation EGFR TKI, and a significant hazard ratio. Looking at the forest plot for the PFS, irrespective of the age, sex, whether the patients were Asian or non-Asian, smokers or non-smokers, whether they had CNS metastasis at entry, irrespective of the EGFR mutation status, whether it was done by ctDNA or a particular subgroup of L858R or exon 19 deletion, all these subgroups favored osimertinib over the first generation. In terms of the CNS PFS, this was essentially looking at patients who had CNS disease or who did develop CNS disease later on. In terms of CNS PFS, we know that this has not been reached for osimertinib till the time that this data was actually evaluated sometime back in 2017 June. And in terms of the first generation TKI, it was somewhere about 13.9 months. CNS progression is less when first line osimertinib is used. We've seen in this graph clearly that patients who were known or treated CNS mets at trial entry, only 19 out of the 279 patients did actually have CNS progression as compared to 43 of the other arm. In terms of overall survival analysis, we have a median overall survival benefit to the tune of 38.6 months with osimertinib as compared to 31 months, with a significant p-value, hazard ratio of 0.79, and this is after 321 deaths in 556 patients at the time of data cutoff. Again, when we look closely towards the forest plot or for the overall survival, we see here that in Asian population, osimertinib may not do that well as compared to the non-Asians, and patients who have CNS disease may do better with osimertinib as compared to the first or the second generation TKI. Patients who are remaining on study and time to first subsequent treatment or that, we see that at 3 years also about 28% of patients who were still continuing the osimertinib as compared to only 9% patients who were on the first generation TKI. Of the 180 patients who were on the comparator EGFR TKI arm, this graph essentially shows what is the percentage of patients who actually went on to receive subsequent line of therapy. The figure on the left shows the osimertinib distribution, the one in purple, which is 47%. The patients received the first subsequent line of anti-cancer therapy. There were 31% patients in the osimertinib arm who did not receive any subsequent treatment, and 22% were still on therapy. Of the 47%, 68% received cytotoxic chemo and about 29% received other EGFR inhibitors. When we look at the EGFR TKI first generation, which was the comparative arm, 65% of patients actually went on to receive subsequent anti-cancer line of therapy, of which 47% received osimertinib as second line, and 22% received chemotherapy, and another 22% received EGFR TKI other than osimertinib. So in terms of safety analysis, when we look at the exposure to the drug, the median exposure to osimertinib has been 20.7 months, and grade 3 drug-related adverse events were 18% in osimertinib group versus 29% in the EGFR TKI group. So conclusions regarding the FLORA study, we know that there is a statistically significant improvement in overall survival with improvement which is extended by about 7 months. Osimertinib was the first EGFR TKI in monotherapy to show a significant overall survival benefit, and we must offer this as an initial line of treatment for most of the patients. Now, in conclusion, this EGFR TKIs in NSCLC has really been a major model for precision medicine approach in oncology. Over the last decade, we've seen 3 generations of EGFR TKIs, either monotherapy or combination with chemo and anti-VEGF mAbs. However, there are certain challenges. The challenges I see are in actually choosing what optimum treatment strategy, because we still don't have data on what happens to the patients who receive first line osimertinib, although there is some data which Professor Tony Mock presented on MET amplification in patients who have received first line osimertinib, wherein immunotherapy, chemotherapy combination is used as second line. We know that these patients are going to do well because we are maximizing the overall survival. However, the optimum sequence of therapy remains questionable. We also know that whichever EGFR TKI we use in first line, eventually all of those patients are going to develop resistance to it, as we are looking at multiple lines of therapy to for exposure to our patients so that they get a better survival. Thank you very much.
Thank you, Dr. Gore. This is very lucidly you have carved out the milestones and also the caution or the challenges that one faces while treating these patients. Good. And I think probably more things will come up and when you discuss in the panel discussions, and we will take it in that session. And thank you so much, Gore.
Thank you, sir.
Yeah. Can we move on to the next one that is in the panel discussion? It's on the optimal management of an EGFR mutated NSCLC patient. And we have a moderator, Dr. Bharat Bhosle. Dr. Bharat Bhosle, can you take over and introduce your panels? Dr. Bharat? Yeah, go ahead.
I think I would. So, Bharat sir, are you there?
I would request organizers to call upon the panelists for this session. Meanwhile, I would like to share the slides. Can you see my slides?
Sure, sir. So, Dr. Bharat Bhosle needs no introduction. He is an excellent clinician and he has more than 15 years of experience. He is practicing in HCG, Nariman Point, SL Raheja, Jaslok Hospital and Bombay Hospital. He has got numerous research papers and also has been a faculty at national and international conferences. He is an active ESMO member. Panelists for this session are Dr. Avinash Talele, who is practicing medical oncologist in Mumbai. Dr. Uma Dangiman, she is a practicing medical oncologist in Fortis Hospital, Mulund and Hiranandani Hospital, Vashi. Dr. Rohit Pai, who is in Bombay Hospital. Dr. Bharat Chauhan, he is in Nanavati Hospital, Bombay Hospital, Sujay Hospital and Criticare Hospital. Dr. Vijay Sharnagat, he is in practicing medical oncologist in Borivali and HCG. And Dr. Suhas Vilasrao Agre, who is a practicing medical oncologist in Asian Cancer Institute, Navi Mumbai and Sumaya Ayurvihar. So over to you, Bharat sir.
So there is one update. Dr. Uma Dangi could not join us.
No problem. She will. I think she is on the way and she will join us subsequently. She has just dropped a message.
Yeah. Okay.
So thank you, Bharat, for now giving me this opportunity to be a part of this very successful conference. So far, you have wonderful attendance and nice data is being discussed. I see a lot of enthusiastic pulmonary oncologists participating in the discussion, this particular discussion. And I hope from the last slide Advait showed, there are challenges because we have a basket full of so many agents for EGFR mutation positive NSCLC. So this case-based discussion, the case capsule is provided by AstraZeneca team. So I would like to thank the Astra team for supporting this particular discussion. So my request to all the panelists, to be precise for what they are doing in the practical life, and they obviously they can use the data. Hello. I think the organizers have stopped me from sharing the screen. Hello.
Ravinder?
So your screen is visible, sir.
Please allow me to manipulate from my side because you have stopped. I think stopped sharing the slide.
No, sir.
I cannot.
You can sir stop share and share it again.
Okay, sir. Yeah. So basically, I would request every panelist to be engage into a discussion which is more of a practical. Obviously, we have to look at the data, but what actually happens on the ground reality is very important when we have so many agents, and we know that for the EGFR positive lung cancer, we have osimertinib as a preferred agent, but obviously at the same time, we have so many other agents which are enlisted as a level 1 evidence. So obviously, all of us do face in day-to-day life. So I will start with the practical challenges. So this 65-year-old female, non-smoker obviously, presented with the left-sided chest pain and evaluated by a pulmonologist, and the X-ray showed some consolidation, the CT done, and there was a pleural-based mass with some mediastinal lymph nodes. The standard investigations were done and the CT-guided biopsy was done. Report was awaited. In the meantime, coming to Suhas, Dr. Suhas Agre, Dr. Vijay Sharnagat.
Yes, sir.
Yeah. So
Yeah, yeah.
when a patient comes to you, you know that there are a plethora of agents available. So how do you approach a patient comes to you with a consolidation or a mass? How do you plan this patient before doing a biopsy? What are the people with whom you interact about this, or you send the patient just for the biopsy and wait for the report?
So I think it would be a multidisciplinary approach first, getting the investigation for the patient, including the normal routine biochemistry, serum, CEA, calcium, along with the we do use PET scan as well as the MRI brain for the staging purpose, and then we'll have a multidisciplinary discussion.
So you do PET scan for all the patients?
I do. In clinical practice, I do. Yes.
MRI brain?
Yes. Yes.
Okay. Anybody would like to differ? Bharat Chauhan? Bharat?
Yeah. I agree with the Suhas regarding the PET scan, but regarding MRI in stage 4, if the patient is not symptomatic, let me tell you, if the patient is not symptomatic or there are no symptoms, I am not ordering any MRI. PET scan I am doing.
Okay.
Yeah.
Yeah. So anybody would like to differ or no? Bharat, Dr. Bharat wants to do MRI in selected cases. Whether the patient is symptomatic or not symptomatic is also important. Anybody would like to add? Avinash, Rohit?
Sir, ALK positive and small cell only MRI brain upfront. Otherwise, in selected cases.
Okay, you want to do MRI brain for selected cases. Great.
Yes.
Okay. So this patient's histology was adenocarcinoma, and on PET scan there were METs. So basically, it's a metastatic adenocarcinoma lung. So what happens? Usually we send the tissue for diagnosis and we get the reports one after the other, or you send the tissue for NGS. So my question to, we'll start with Rohit only because he has answered the last question. So Dr. Rohit.
Yes, sir.
So now we have so many agents targeting different mutations. Also you have immunotherapy drugs, you have targeted therapy drugs. How do you plan the investigation, the molecular investigations, or what are your instruction to the pulmonary pathologist? How do you get the discussion right from the histopathology?
So first of all, I prefer to mention that please do only a limited IHC panel just to establish the histology, no detailed IHC. That is number one. Number two is I am still doing selected markers only. So ALK by IHC D53 probe, EGFR by PCR, and ROS1 screening by IHC along with PDL1. So till now, I have not started ordering NGS panels or something like that in my routine clinical practice. But limited IHC along with that selected panel. If the tissue is very less, I request my pathologist to inform me. In those cases, definitely, I would order NGS.
Yes. So this is very important. If there are students listening to us, I think there are a couple of students attending this meeting. It is very important when you have a patient of lung cancer with you and you send the patient to the radiologist for the biopsy, you have to have a crosstalk. This crosstalk also important to reduce the resistance to the tumors, kind of a thing. I always have a talk with your radiologist. Because what happens if the radiologist does the job perfectly, your rest of your planning goes smooth. Otherwise, you end up in getting inadequate tissue or the complications or your histologist. Again, the second point Dr. Rohit said is limited IHC. It's very important. As there are some labs, if you don't interact with them, they end up in applying all the possible markers in the available. And at the end, when you request them to send the tissue to the molecular pathologist, the answer comes that there is no adequate tissue. So this is, I think, the critical step in the management of lung cancer. And my panelists, most of you are practicing lung cancer, all of you are practicing lung cancer, and you all are doing the same thing, I assume. So going ahead, as Dr. Rohit said, at present, he may not consider sending the tissue for NGS for all patients. Then my question to Avinash, Dr. Avinash Talele, or Dr. Bharat Chauhan can take this question.
Yeah, I will.
Bharat, we end up in getting those tests like PDL1 or ALK, which are done by IHC immediately within 2 days or 3 days. So what happens if you have a patient sent for the tissue biopsy for the molecular analysis and you get a PDL1 score of 95%? That usually happens. Those tests by ALK or IHC you get first, and EGFR is because it's by RT-PCR, it takes some time and it is available after 7 days. So this patient is stable or moderately symptomatic, and the PDL1 score is above 90% or 85, whatever. So would you like to act upon that, or you would like to wait?
A very important clinical scenario which we face daily. As you have rightly mentioned, PDL1 comes first. So for me, I will see the clinical part of the patient, like whether it's adenocarcinoma, patient is smoker or not, female. These are the very important part. If the patient is stable, then I will wait for few days. As you mentioned, the patient is symptomatic, then I feel then we have no choice. He may deteriorate any time point. Then it is better to give immunotherapy or chemotherapy with that. But I would like to wait. I would not act upon PDL1 because for me driver mutations are very important. So I will wait. The patient can wait, and patient is not anxious, and patient is not symptomatic.
This is very important, as rightly told by Dr. Bharat Chauhan. Even if the PDL1 score is high, we really have to wait for the mutation test, because if the patient is female, non-smoker, the probability of ending up with a mutation positive patient, like EGFR is almost from 30 to 33%, ALK is 4 to 5%. Again, the ROS is in the range of 2% or 3%. So we have to wait. In exceptional cases where the patient is symptomatic, you have to treat the cause, like patient sometimes presents with the massive pleural effusion. If the patient is symptomatic due to bone metastasis, you have to act on that. Yes, as told by Dr. Bharat Chauhan, you have an option of adding or starting with the chemotherapy also. Immunotherapy with this score, yes, plus minus, but we have a data which shows that actually those patients with mutation positive may have a worse result with. I'm not able to move the slides. Anybody would like to add something on this? Rohit?
Oh, agree with everything. Wait for the driver mutation report before considering immunotherapy.
Ravindra, please check. He's not able
to.
Yeah.
Bharat, can I ask a question?
Yeah.
Advait here.
I am the moderator. I will ask the question. Please go ahead. You can ask.
No, what do you do? What do you do in a case where a patient is symptomatic? Because we do come across patients who are actually symptomatic, and you don't have the panel with you, and then you are left with no option but to actually start something for the patient for symptomatic relief.
So
would you go by the clinical criteria and start this patient on an EGFR inhibitor, or would you start this patient with a pemetrexed platinum combination?
Very interesting question. You said you don't have panel with you, but I have a full panel with me. Dr. Chauhan, Dr. Rohit, excellent panel. So anybody from the panel would like to take this question?
Pem platinum.
I would like to answer this question.
Yeah. Rahul?
Rohit wants to say something.
So I would go for Pem platinum if there is only on the basis of histology.
Yeah. Right. Anybody else?
Avinash here. So first I would look for the reversible causes, like this patient had a pleural effusion. Training the pleural effusion, and if he or she could get some symptomatic relief, and despite that, if patient doesn't improve, then I would go for some pemetrexed adenocarcinoma. If we have in hand, then I would go for pemetrexed based doublet chemotherapy, induction chemotherapy.
So Advait, I think we have an answer that when the patient is symptomatic, you assess the performance status, you assess the renal function, obviously all the other blood workup, everything, creatinine clearance. You have to be very sure the patient has adequate renal function before using the pemetrexed. You should you have to make sure that the patient's pleural fluid is properly drained. Otherwise, we end up in getting the pemetrexed toxicity in some cases. You have to make sure that you have given the loading dose of B12. Again, the duration before pemetrexed to use B12 is from 1 week, or you can use within few 2 or 3 days also. There is some data. You can give vitamin B12 a day prior also and start the pemetrexed. It depends on the patient's clinical profile. I think we have no answer. Now, Advait, I would like to ask you the question, last question. Advait?
Yeah. I'm here.
I had few cases, and Dr. Rohit is also aware about that. So we tried to do the biopsy, and we ended up in getting very small tissue, but accidentally there was a pneumothorax. And the patient, we tried to convince the patient, obviously, but they have a pneumothorax which required the intervention and ICU admission. The patient was not ready for the repeat biopsy. And in that scenario, it becomes difficult. Then I spoke to the pathologist. He said there are 4 cells only, and I could do whatever limited biopsy, and I exhausted with those 4 cells. And it is adenocarcinoma lung. Patient is a non-smoker, well fit into the in the clinical characteristic which may show a mutation positivity. In such cases, when you don't have a tissue, would you like to start like a compassionate basis TKI because EGFR is present in 30% of the cases, or you would like to start with the chemotherapy, or you would like to wait till the pneumothorax resolves and again try a biopsy, or would you like to go for a liquid biopsy, which is again an option for us?
Very difficult question, Bharat. I think you have a good panel with you, but what I would do is I would probably ask a liquid biopsy in this situation if patient is absolutely not willing and you have a histopath diagnosis of adenocarcinoma. You can get the information on EGFR, ALK, ROS1 on liquid biopsy also. You may not be able to do a complete whole NGS, but you would be able to get some information on EGFR based on liquid biopsy. But I would probably still talk to the patient that it's better that you have a tissue diagnosis rather than liquid biopsy.
Thank you, Advait. So that option remains. If you are not able to, you are not in a position to obtain a tissue, the last resort. Obviously, we have to encourage the people, patients to undergo a tissue biopsy because that is the standard of care. But in certain exceptional cases, we actually have end up in doing no liquid biopsy only for EGFR, not for the other mutations. But the question for all the panelists now, with the availability of more actionable mutations like BRAF, HER2, MET, RET, anybody using liquid biopsy to have a NGS or sequencing of all these mutations except the PDL1? Anybody can take the Avinash and Suhas. You are working in Onco Center, one of the largest Onco Center.
I don't think we are using commonly as a liquid biopsy for this test. Only we are using from the solid tissue diagnosis only. And not all these tests, maybe some routine tests. And if those come negative, then only we go ahead with the rest of the mutation panel.
Okay, thank you. Anybody would like to add about the liquid biopsy? Avinash, Rohit?
No, I agree. In these cases, obviously, it was a very good thing which liquid biopsy was done in your one of your patients. But at progression, after EGFR inhibition, second line, eat liquid biopsy. That is the place which I
accepted.
Can I just add a word over here? Amit Bhatt here.
Amit, welcome.
So because liquid biopsies, I jumped in. So just a point to note, the American Cancer Pathology Association clearly mentions that yes, all the molecular markers have to be done on a tissue sample, but if the tissue sample is not there, their document does mention EGFR, ALK, RET, and BRAF, which can be done on liquid biopsy. Yes. We don't have that kind of facilities available here, but yes, if that is there, if someone is going to give you a validated sample, then you can do all the 4 on a liquid biopsy. Obviously, PDL1 is not to be done. And one more addition, where the case which Bharat said, that the patient is not ready for anything, we can't empirically give EGFR because that's, from legal point of view, it's illegal. So you document that and just give chemotherapy, which is the standard of care, which was standard of care 10 years back. So maybe if the patient is refusing every treatment or liquid biopsy or the rebiopsy, just document it and you'll be legally safe. Just giving them carbopen, as Dr. Pai said, the carbopen is the standard option. Thank you.
Yes. So it is very important when you don't have a mutation reports and to use TKI as a compassionate is not legally right, because one of the curves Dr. Advait shared in IPAS trial in mutation non-selective patients. If you look at the mutation versus no mutation, the Jaftinib actually was detrimental to those patients as compared to the Gemcobra. So based on the patient's performance status, you can decide which chemotherapy. Obviously, it is the clinician's decision. But in some cases, Amit, I would want you to share your experience of liquid biopsy for upfront mutational analysis, if you have any. I think you use precision medicine. So what is your experience?
So we have done a lot of liquid biopsies for EGF and ALK both through a genetic partner of ours, and then we have quite good results. We have obviously rechecked them with the standard biopsy report, but for clinical decision making right now, since it is not
No, that's okay. But your experience, is it only the EGFR or ALK and
no,
ROS
yeah,
also?
we can do all EGFR, ALK, BRAF, and RET. All these are easily done. You get enough sample and you can easily do it on the tumor cells on a liquid biopsy.
Excellent, excellent. Thank you for your inputs. So basically, about the brain, MRI brain, with lot of patients coming with EGFR, ALK, ROS, and we know that they end up in getting metastasis during their course of clinical course over a period of time, a month or year. So to do or not to do a MRI brain is, again, we have addressed this question, and Dr. Bharat said and Dr. Rohit also addressed in certain cases he would like to do. So again,
Can I add one thing over here?
Yeah, please.
So I think getting the MRI brain at the baseline would be very important, even though the patient are asymptomatic, because ultimately we can select the treatment based on the CNS status. That is what important nowadays is, based maybe on EGFR or ALK status. That is what I would think personally is important to get a baseline CNS investigation.
Yes. So this is very important. Like and guidelines are evolving over a period of time as more and more data come. So previously we never went on to do MRI. Then we started selecting the patients. But especially when we look at the mutation positive patients, and when there are different agents which can be preferred one over the other with certain selection criteria, then getting a MRI or discussing at least MRI brain in the case of CA lung becomes very important. And you can see here the NCCN guideline 2020 mentions, if not previously done, get the MRI brain done. And for EGFR, I think it is very, very important. That is important, especially if you have a metastatic disease, which can be oligometastatic, which can be targeted with there are non-chemotherapy or non-targeted therapy modalities like stereotactic radiosurgeries also can be considered. So according to this updated NCCN guideline, all patients should undergo brain MRI if not previously done. Again, you can justify based on whatever clinical profile of the patient you have. So this patient was adenocarcinoma, PD-L1 was high, and EGFR exon 19 deletion was positive. So coming to the first line therapy, Dr. Rohit Pai.
Yes. So cost no constraint, osimertinib.
So osimertinib for exon 19 deletion, you will straight away counsel the patient for osimertinib. Okay, great.
So yes.
Anybody would like to differ, or everybody agrees with osimertinib?
Agree.
Yeah. So question is like preferred systemic therapy, and the guideline clearly mentions preferred systemic therapy. So whenever you counsel a patient, you have so many options. You have chemotherapy, you have immunotherapy, chemoimmunotherapy. Obviously for EGFR, nobody would like to choose chemotherapy alone or immunotherapy or chemotherapy. There are agents, first generation, second generation, third generation. Advait has gone into the details and what are the combos available with no level of evidence. So we have discussed this part. Even the PD-L1 is high and you have targetable mutations, we would not go for immunotherapy, as that can be detrimental in mutation positive patients. So apart from, suppose by some reason, any reason, I would not quote that the cost is an issue, but the patient doesn't want to go for osimertinib. You have excellent, this is the best drug, least toxic, the best PFS, and there is no support. Or patient says, I cannot go for this therapy. So then what are your goals of therapy, and what therapy would you like to choose, and based on what data? Dr. Suhas.
I think in that case, I would like to discuss with the patient about selection of the second generation EGFR TKI over the first generation, as we have clearly seen in those clinical trials from the Lux Lung and as well as the dacomatinib trial, that these are the superior as compared to the first line EGFR TKIs, although there will be some of the side effects. But I think in the clinical practice, as we move on to the therapy, initially it becomes slightly difficult to manage, but once maybe 1 month or maybe so, after that patient usually gets adapted and the side effect becomes lesser and lesser. So in that scenario, I would definitively discuss the option of the second line EGFR TKI, particularly the afatinib over the first line agent.
So thank you, Dr. Suhas. Dr. Avinash,
Yes.
would you like to go for afatinib only in exon 19 del mutation, or would you like to go for all the mutations, irrespective of whether it's a common sensitive mutation or non-sensitive?
So I would like to, across all afatinib, I would prefer afatinib across all the mutations.
Okay, so if you don't have an option of using osimertinib because of any reason, so you would like to go for afatinib.
I would go with the second best, yes, with the afatinib.
Second best is afatinib. So good that no, we are coming osimertinib, then the afatinib. So coming to, has Dr. Uma joined so far?
No, I can't see her.
So Vijay, Dr. Vijay.
Yeah, sir. Yeah.
We have the best is osimertinib. If
Yes.
that is not done, you have afatinib
Yeah.
and
Dacomitinib.
dacomitinib. So any experience using dacomitinib?
Yeah. I do have experience. I got that maybe on the compassionate basis for one of my patient. I have started her straight away with dacomitinib. So the thing is that the side effect profile. So the tolerance. So initially, when patient started it on first time, so patient took it for like 15 days and left that because of the complications like stomatitis and all. She got and she afraid of that thing and she stopped taking that. So she got progression after 4 months. And again, I have convinced her regarding the therapy, and she again restarted with the treatment. And now she is showing better response. So this is the thing which I faced, clinically. So that is my experience.
Dacomitinib, because of the toxicity, he stopped and
Yes.
restarted
Yeah.
lower dose of the same drug or any other drug?
No, restarted with the same dosages and everything, and I have convinced her, and she agreed with that, and now there is, I think, a good response, and she's tolerating the drug very well after 2 or 3 months.
Thank you for sharing your experience. Anybody else who
Yeah.
has used dacomitinib as a compassionate or for a routine, because now the drug is also available, I think, in India. So the problem with the dacomitinib is toxicity, as Dr. Vijay rightly said, and then you have to counsel the patient, or sometimes you have to go down with the dosing, and there is some data from the real world that lower doses also have reduced toxicity and equal efficacy. So this patient, so you can see about the immunotherapy, we have discussed that immunotherapy actually could be detrimental in EGFR positive patients. So that should not be the treatment of choice. This slide has already shown, and the preferred option we have discussed. You have first generation, second generation, third generation. Now coming to the options of combination therapy, you can see the ramucirumab, erlotinib, that relay data of a very good progression-free survival, nearly 20 months. Then you have heard combination like erlotinib, bevacizumab, which has been checked in phase 2 trial, then in phase 2 NEJ trial, which has also shown a progression-free survival of almost 21 months. Not 21 months, it is around 17 months. Then you have a combination of chemotherapy and jaftinib tested in India as well as the Asian population of some Asian countries, Japan, I think. So you have a progression-free survival of 21 months by combining a first-generation TKI with combination chemotherapy. Anybody would like to take this? You have an excellent progression-free survival. So any group of patient where you cannot offer osimertinib or afatinib, you have a combination chemotherapy with which can be cheaper than afatinib or osimertinib. Dr. Suhas.
But sir, I think with the cost of afatinib now, with the generation with the generic.
So if somebody doesn't want to take osimertinib, so any reason, don't talk about generic. So you have a data.
Right.
Progression survival, it is 11 months, 13 months.
Yes.
Combine jaftinib with doublet chemotherapy, you have progression-free survival of 21 months in Japanese population.
Yes.
Have progression-free survival of somewhere around 16 months in our own Indian population.
Right.
Published from India, Mumbai.
Yes.
On that, I'm not asking you to use it, but
Right, right. So I think that the data is very exciting, but still, since we are having quite a lot of treatment options, maybe until unless the patient refuses for the particular treatment, then maybe we can choose for the chemo plus gefitinib combination. But still, maybe some more trial can help us to select this particular strategy.
Plus, we have two trials, NEJ 009 and Tata trial. Now, how many trials?
Yeah, even we have the TMS data there. No, we have PEM-JEF. Yeah,
But will you use in the clinical practice? That is the most important question.
It is a clinical data.
Anybody using it? Avinash?
Yeah.
Yes. Yes, Dr. Bharat. Please go on.
Yeah, please share your experience. What are the challenges?
Yeah, I have used in two patients, afatinib because there was some CNS metastasis also, and there was a local lesion in the lung also, and we were thinking of subjecting him to local therapy later on because patient was really highly motivated for the treatment. So I have given afatinib plus chemotherapy.
Oh, excellent!
It was totally intolerable. I have done in two patients, and it was toxicity was too much. So I would say it is toxicity. Maybe others can share the experience, but for me, I think toxicity is
that was afatinib plus chemotherapy, right?
Yeah, afatinib plus chemotherapy.
Okay, so we don't have a data to phase 3 for that. But your intention was to treat with the curative intent, use and chemotherapy, bring down the disease burden, do radiation or stereotactic or radiosurgery to the brain.
So we have
it's kind of a new adjuvant combination. Okay.
Yeah, we have planned for proton therapy for that patient, but somehow the toxicity was too much. After second cycle, I have to stop afatinib. So I continued with chemotherapy at that point of time, in discussion with oncologist at Apollo Center for Proton. So after 3 cycles, he had a very good response. We did proton for him. So now the question again, there was a good disease, disease burden was significantly less, and almost the lung disease vanished. So now there was the question is really open for discussion.
Bharat has brought a very good point. See, there is a data of combining first generation with the doublet chemotherapy. And with that hypothesis, now people are asking to combine osimertinib with the chemotherapy. So the answer is at least you cannot combine afatinib because afatinib with chemotherapy is too toxic. What from the experience of Bharat, we can see. And yes, afatinib when combined with cetuximab also there is data that it's become too toxic. So maybe afatinib is not meant for combining with other agents, or you may have to combine it with VEGF. So anybody, Rohit?
Yes.
Have you tried VEGF?
Yes. No, not VEGF, sir. Chemo plus gefitinib. So there are a couple of patients, and I feel that rash and diarrhea are somewhat of an issue, but reasonably well tolerated. In a fit patient, reasonably young patient, not affording osimertinib, chemo plus gefitinib, I will consider because
Dr.
Rohit.
Yes, go ahead, Swas.
So what is the longest PFS that you have seen with this particular complex?
One is ongoing, sir.
Practice?
So one is actually ongoing. I think around 10 months down the line. I would have better information down the line, sir.
Okay.
please
Yes.
go ahead, Avinash.
Yeah, sir. I have started on 2 patients post erlotinib. So erlotinib, bevacizumab, I have 2 patients, and one of them is doing well.
So interesting. You actually added VEGF on progression, right?
Yes.
So if you look at the data there is a data to say that you can combine chemotherapy with TKI, and the control arm where no TKI was ongoing, people have added chemotherapy also later on. The PFS was comparatively same, but you end up in getting lesser overall survival. Depends. So that also strategy. So it is better to hit the nail hard at the beginning. So whatever you want to use combo, you can use it in the beginning, but except the osimertinib. So this is about don't go on the comparisons. You cannot compare these different trials, but you can see in Lux Lung 7 where the first generation and second generation was compared. The PFS, the numerically more or less same. In Archer, you can see dacotinib and gefitinib. Till 6 months, the curves are overlapping, and after that there is a separation. But when you look at the osimertinib data, the separation is immediate. So that is maybe the beauty of this particular drug. That is why maybe the guidelines also says it's a preferred option. So in the flora, you can see the curve separating right from the beginning, and you can see the brain metastasis were not included in the second generation documentinib. Brain mets were included in the afatinib and flora data. So that is why it becomes the preferred agent. Now, toxicity wise, I would not go into the details because we know that osimertinib is very well tolerated. You cannot compare the toxicity of osimertinib with the other agents. So definitely by tolerance wise, it is the best among all. Responses also, you can these are comparable. And look at the median PFS. You can see only the Japanese and chemo combination from the Japanese population is ahead of this particular osimertinib. But again, toxicity, as mentioned by Dr. Suhas, is major concern when you combine chemotherapy with the first generation TKI. The patients with brain metastasis, again, in that case, it becomes very important to have a MRI brain in the beginning. So if you look at the brain metastasis PFS, it is better with the osimertinib. Again, if you look at the combinations of VEGF and TKI and Gefitinib chemotherapy, the survival is not significant. So overall survival updated data from Flora, you can see the median overall survival is nearly 39 months with a hazard of 0.07, and it was statistically significant. Safety, I have just mentioned that osimertinib among all is the most tolerable drug. And just now the problem with the afatinib. In the beginning, we faced a lot of problems with the afatinib also, and there were dose modifications suggested. But over a period of time, it is about the time, over a period of time, the patient develops tolerance. And for certain group of patients like EGFR19, afatinib also sometimes is a good drug. There is a real world data will come to that. So this is about dacomitinib, and dacomitinib toxicity, Vijay had just mentioned. I don't have personal experience. Anybody would like to add their experience about dacomitinib?
In the meanwhile, Dr. Bharat, this is Dr. Ramesh here. Can you, you have another 4 minutes to go?
Yeah, I'm finishing. I'm finishing. I'm done with the questions. Yeah. So this is about the dacomitinib. Clearly, I can see there is a lot of toxicity with this drug, and when we compare with the Flora, definitely the osimertinib is the most tolerable the drug among all the groups. So in the first line, obviously, most of you have already said that osimertinib is the first line option. And though the sequencing is an option, we all prefer, but because of the logistics and the cost, most of the time we end up in not prescribing. Then what to do? So if you don't offer the drug in the first line, you can see if there are 10 patients who are EGFR positive, ultimately only 3 are eligible for second line osimertinib, which is indicated for only T790 mutation positive patients. So it is better to use the best drug in the beginning. There is a real world data of geotag where afatinib followed by osimertinib, but again you have to look at it. It's a retrospective data. Brain mets patients were not included. Majority of the population was deletion 19. We know that afatinib works better, preferably in this particular mutation population. So these all points needs to be taken into consideration. And for you can see still so 20% of the patients with mutation comes with brain metastasis. This is again a most important point. So those patients who do not have brain metastasis, there is a possibility they may develop. And if you use a better drug in the beginning, so you can see 60-70% of the patient eventually develop brain metastasis. And here I think then osimertinib has no right to be preferred agent over the other agents. This is the CNS progression-free survival graph shown already by Advait, and definitely the osimertinib works better in this also. So conclusion is that osimertinib, yes, looking at the PFS, OS, and the response rate in the CNS, it has to be preferred drug. It has demonstrated significant and meaningful activity in the CNF over standard of care. It's the first TKI to show statistically significant OS benefit over other TKIs. After 3 years, 28% of the osimertinib patients are still, as compared to 9% in the comparator EGFR, remained on the first line treatment. So that's a significant number. And that's why osimertinib is a favorable for all of us, and it's a preferred agent for EGFR TKI. Thank you. Thank you, organizing team, Dr. Bharat and AstraZeneca for giving this opportunity. I would like to thank the chairpersons, my panelists for giving their practical inputs, and over to the organizers. Thank you.
Thank you,
Thank you.
Dr. Bharat Bhosle.
Thank you, sir.
And well now taken, and now you have really used your panel and your armamentarium and very well, and you could able to really convince the summary that you have enforced or told us. That's an excellent way of presentation. And I thank all the panelists and also the organizer. And the talk of Dr. Gore was also very, very informative, and it laid a foundation stone for our panel discussion. And Kaushal Gupta, and I hand it over to you and to the organizer to further conclude this. Kaushal.
Thank you, sir, for chairing the session. I hand over the next session, the reins of the next session to the organizers for the next session.
Yeah, Ravinder.
So we have 97 people live now who are watching and hearing us.
Okay, that's great. Dr. Siddharth Tudkar is a renowned medical oncologist, and now he will take over. Dr. Siddharth, thank you for joining us.
Thank you. So to start my session, I would like to invite the chairperson, Dr. Dhaireshil Sawant. He's a senior consultant surgical oncologist, Asian Cancer Institute and Bridge Candy Hospital, Mumbai, and Dr. K.S. Panda, who is also a senior consultant surgical oncology in HCG Hospital, Cuttack. Doctor, they are there.
Hi, everybody. A very good evening. Thank you, Bharat, and thank you, Siddharth, for letting us be here. I don't know, is Dr. Panda here on the screen?
Yes, yes, I am here only.
Good evening, sir. How are you?
Fine, doing.
Yes.
All right. Thank you.
Dr. Sarkar is also there, na? He is also a chairperson. Dr. Sarkar. Dr. Sarkar, are you there?
Yes, Bharat, very much here. Hi, there you.
Surgery oncologist at Nanavati Hospital. Thank you, sir, for joining us.
Without any further ado, let us go to the first part, and that's the panel discussion, which will be moderated by Arvind. Arvind is a dear friend and is a senior surgical oncologist at WI Adyar Cancer Institute. He's going to conduct a panel on multimodal treatment of locally advanced cancer of the oral cavity. Without further ado, Arvind, go ahead.
Yes, sir. Thank you, Dr. Sawant, and the organizers for this meeting for calling me. This panel is on the multimodality treatment of a locally advanced case of oral cancers. These are my panelists. I just wanted to confirm from the organizers, are all of them there, or anybody?
I will invite everyone one by one.
Okay.
Dr. Siddharth Sahay, Senior Medical Oncologist, Max Super Specialty Hospital, Mumbai. Dr. Rohit Malde, Senior Radiation Oncologist, Nanavati Hospital, Mumbai. Dr. Akash Shah, Senior Medical Oncologist, Apollo and CBCC Cancer Hospital. Dr. Rakesh Katna, Consultant Surgical Oncologist, Fortis Hospital, Mumbai. Dr. Bhavin Visaria, Consultant Radiation Oncologist at Seven Hills Hospital, Mumbai. Dr. Rohit Pai, Consultant Medical Oncologist at Bombay Hospital, Mumbai. Dr. Avinash Talele, Consultant Medical Oncologist, Mumbai. And Dr. Darshana Rane, she's a Consultant Medical Oncologist, Nanavati Hospital, Mumbai.
Great. So, apart from Dr. Chandraveer, everybody else is there.
Yeah, I am here, sir.
Oh, Chandraveer. Oh, great.
Yeah.
Wonderful. So everybody's there. Wonderful. Okay. I think we'll directly go for a case scenario, and that's the best way. We have a multidisciplinary panel of every specialty, surgeons, medical oncologists, and radiation oncologists, obviously medical oncologists outnumbering. This is a young male, 30 years, a chewer of 20 years, young, fit, performance status 1, locally advanced carcinoma right buccal mucosa. This is something that we actually see day in and day out in our outpatient. This gentleman coming with disease in the right buccal mucosa, involvement of the skin, and also extensive soft tissue involvement reaching up to the zygoma. This is by a clinical stage, it would sort of be T4B N2. I don't really want to go into the staging nuances, which I'm sure that everybody in the panel are aware, and everybody in the audience is also would be aware. Refer to the classical TNM staging. And this is the T4 disease, T4B disease, classified according to the TNM classification. masticator space, pterygoid plate, skull base, and encasing carotid artery. Now, I just want each one of the panel, and this is the clinical picture only of the gentleman, to say whether this patient can be considered for a curative treatment based on the limited clinical data available, or would it be a case of palliative treatment? I think I would like to start with this. And since we have too many people in the panel, please feel free to chip in at any point of time. And I will not be calling you all individually by names, but then I'm sure that each one of you all can sort of, please contribute to it. I would first start with surgeons in the panel. Dr. Chandraveer, you're there?
Yeah, sir.
Yeah,
because sir, there is a T4B lesion basically involving the mesenteric space, pterygoid, and encase the carotid artery. So this is basically unresectable disease, and so we will give the first we give the NACT to reduce the tumor. So this is the unresectable tumor basically.
Great, great. So you want to say that, would you consider surgery at any point of time? That is the mood.
No, sir. This is unresectable because there is a involvement of the skull base and involvement of the internal carotid artery.
No,
this is the unresectable tumor.
No, I'm sorry. I just gave these. The list of 4 are basically the classification of T4B. So this is not there. All those things are not there in this gentleman. I just showed you a clinical picture.
If there is a known the anatomically vital structure of picture, there is no involvement of the base of skull, no involvement of the internal carotid artery, so we can resect this.
Right. Rakesh, you want to sort of chip in?
Yeah. So, am I audible?
Yes, Rakesh.
And it's definitely
not clear, Rakesh.
Going
can
to
you...
the involvement of the masticator space.
Correct.
Okay.
So there are 2 issues in here. That is, there is a masticator space involvement that we can make out clinically. There is a skin involvement that we can make out clinically. That is why it makes it a T4B. The other things we are not aware. So given this, what are your initial thoughts?
So when we look at this kind of disease, definitely is a T4B owing to the masticator space involved in an extensive soft tissue. Now, if you see the edema is going above the zygoma and similarly posteriorly towards the parotid area. But this patient can be considered, this is called as intermediate to high ITF kind of a disease.
Great.
So I'll not deem him off the surgery scenario anytime. I'll still looking at his age and other GC status is good. He might come for a curative resection later on. As we know, ITF clearance is feasible in T4B also, but not at this moment. So this patient ideally will go for a neoadjuvant chemotherapy maybe.
Great. No, we'll come to that. Rakesh. So great. Sure. I think very excellent points made by both of you all. I think, as I said, the moment the patient walks in or outpatient, we get to know some idea of the disease. This is clearly, as I said, retreat T4B because of extensive soft tissue skin involvement. But this does not rule him out of a potentially curative. Just because you're seeing a gentleman with such an extensive soft tissue, you cannot rule him out. That is what the panel seems to suggest, and that is the larger meaning. And if everybody in the younger people in the audience get this message, I'd be really happy. This panel is actually in a way well done. So now let's actually go about going for this treatment. Initially, prior to that, I just wanted to have some thoughts from everybody else with regards to the young age of this gentleman. He is around a 30 years old gentleman, and anybody else I would want to chip in with the association between age and oral cancers, and what are their thoughts, and how is the practice, what are they seeing the age profile of the patient. Dr. Rohit, you're there. I can see you in the screen, so you could possibly chip in.
Hello.
Yeah, go ahead.
Yeah, so younger age and cancer, so it's quite common because people start chewing at during school times and everything. So not 30 to 40 is quite common, especially in a government setup. I work in Nair Hospital also. The second thing is for this patient, we can hit it hard with neoadjuvant chemotherapy like triplet therapy, which can be tolerated. So definitely the intensity of treatment, intensity of neoadjuvant chemotherapy will be better, and we can consider giving a triplet regimen, DCF-like thing in this patient. Definitely.
Great.
Those are my thoughts.
Yeah, so it is there. So we are seeing more and more of younger patients with cancer, and this is contrary to what is there commonly described in the Western. As usual, a lot of cancers we tend to see a decade earlier, and head and neck cancers also there is a tendency. The other issue I wanted to bring about, and anybody can chip in.
Arvind, I just wanted to make a comment here. I think we are seeing a lot of these younger patients with submucous fibrosis. This is because you are seeing them with gutka, and this is a very specific issue which you see more in Western India. A lot of younger patients with gutka, with SMF and malignancy, and so that's something that younger age and head and neck cancer needs to be addressed a little more than other
Absolutely,
factors.
sir. Absolutely, I agree very much. The other moot question is that, what are the thoughts for everybody with regards to the younger age and the prognosis? Do you sort of, how do these patients fare? This is just a general thought, and anybody can chip in for this question.
Yeah. So, Dr. Arvind, so as we generally,
please go ahead.
what we put in is that younger patients tend to have a worse prognosis or an advanced kind of a disease at presentation and later on in the terms of the prognosis view. But we evaluated, and our article is due to come in SAGC maybe next month, and we could not find any correlation between the age. We divided them into less than 40 and more than 40. But there is enough literature available which says that the patients at the more younger age group, they do actually worse. But simultaneously, these patients tend to have more resistance, more benefit towards giving adjuvant chemoradiation. They tolerate it better also. So we don't know the questions yet. But yes, very young age group, less than 20 maybe with the genetic mutations, very bad prognosis. But in 30 to 40, as Dr. Sawant has also told, this is the age which, because of that, started so young. So that is this. So I don't know whether the age has really got factor in our population as compared to the Western one.
Wonderful thoughts. In fact, I also have some opinion on this. Yes, Dr. Panda, please, sir.
The young male adults are the main victims because they start tobacco quite early. Young male adults.
I agree, sir.
Around 30 to 40.
Anybody else has got a similar experience of age not being a contributor to prognosis in a way?
I feel that they do as compared to the others.
Great. And, no, I entirely agree with what was said. The issue is that we all tend to think that younger the patients, they always tend to do poorly. But what has been showed in number of Indian studies, from what I could see, is that younger patients are associated with bad tumors. These tumors tend to have more adverse features like, extranodal extension, perineural extension, extensive soft tissue, and that is why the tumors do badly. Whenever they have been studied in multivariate analysis, young age has not actually proven to be an independent prognostic factor for adverse outcomes. So it is not to do more with the age, it is to do more with the biology of the cancers which the younger patients tend to act, and age per se may not be an indicator. So the larger message I wanted to give across to the audience and everybody is that the treatments absolutely don't differ, whether it is a younger age or an older age. It is just that we treat the cancers, and some of these cancers tend to have a slightly adverse biology. So these are some of our thoughts also. In fact, I second what was said. We see more of lung cancers. We see of non-tobacco user cancers as well. And this is a trend of younger patients, non-tobacco user cancers, especially of the tongue, which we see. Although we know that buccal mucosal cancers predominate, tongue and buccal mucosa constitutes to about 50% of all oral cancers and all other subsets, the remaining 50%.
But Arvind, having said that, when you talk about buccal mucosa, it is nearly exclusively with tobacco related. When you talk about tongue, there are a lot of co-founding factors which come into it. So your study was correct. When you talk about tongue, there are a lot of other things which come into it, which may be non-tobacco usage also. But for buccal mucosa, I think nearly all of them are
yes, sir. Yes, I entirely agree with you. The conclusions of our study, in fact, I skipped it in view of time, but I would reiterate. 85% of our buccal mucosal cancers present in advanced stages, and a lot of them were associated with tobacco. But 50% of our tongue cancers came in early stages. Maybe they have some pain, they came and they were not associated with tobacco. So this was some interesting finding that we found about a decade back, and this is the trend that we are continuing to see. Exactly right, as Dr. Sawan said. So I think what I'm trying to say is we possibly believe, and I think this is sort of, anybody can chip in, that possibly these tongue and buccal mucosal cancers itself are slightly different inherently. Like, so any thoughts from anybody from that aspect with regards to, of course, tobacco association is there, tobacco more with buccal. Anybody else wants to chip in this particular aspect before we move on to this particular case?
So again, one should not
the
forget.
number of tongue cancer cases are increasing.
Right.
Than our younger days. Now
Yes,
the
sir.
number of tongue cancers are increasing. I don't know why, but the number is definitely increasing.
Absolutely, sir. We tend to operate. Yes, Dr. Sawan.
Also not forget about HPV, which is now coming in a big way. We used to talk about oral tongue, but base tongue and oropharynx. Again, tongue per se is coming to a different. We always thought HPV is not going to be a disease of our continent, but it's coming up. It's not. They are not small numbers. And
The incidence of nodal metastasis is so high in the tongue that makes the prognosis much worse as compared to the buccal mucosa.
Absolutely. Points well made. HPV, of course, more in oropharynx, tongue. A lot of studies are still going on. We need more data. But to move on with this particular case, I don't really want it to go to the type of biopsies. Let me say the biopsy was done, it was a squamous cell carcinoma, and let me directly go to the choice of imaging. So in such a patient, would everybody consider a PET CT as a modality? Let me be really very clear in my questioning. Would you consider a PET CT for this particular gentleman, or would any other choice of imaging be there? Anybody can sort of chip in, especially people who have not spoken thus far.
So local image plus CT chest will be enough.
Right. Yeah, I agree. I think so. Do everybody in the panel believe that a CT of the chest needs to be done for this gentleman?
Yeah.
Great. Yes, wonderful. I think thank you for bringing that point out, Akash. I think it's pretty clear that this gentleman but seeming to be a locally advanced cancer. Imaging of the chest is mandatory, and a lot of us would do a CT scan of the chest. And you won't be wrong if you consider to do a PET CT also for this particular gentleman, and as would be possibly the real world practice. Although if you go strictly by evidence, a good CT of the head and neck and possibly a CT of the chest would sort of suffice, and especially show so if the patient is having possibly a history of heavy tobacco use and fits into the NLST criteria for lung cancer screening, more so this would be a candidate for imaging of the chest. Now again, coming to these, and these are the factors, and some of them the T4Bs have highlighted in yellow and some have not highlighted. Skull base, internal carotid artery. So do we all have a consensus that we are not going to operate on these patients? Dr. Rakesh?
Yeah. So if you see the points over here, skull base involvement and the internal carotid artery, yes, a big yes, that these patients should not be operated, can't be operated. It's a high ITF according to the classification. When we talk about the masticator space, now it starts from your medial pterygoid, your masseter muscle, retropterygoid also. So earlier we used to follow the Liao's criteria, supranotch and infranotch tumors. Infranotch are actually as good as treating T4A tumors. So these should be operated at the outset immediately. The problem is having the supranotch or the posteriorly based where pterygomaxillary fissure is involved. Now those patients should be given neoadjuvant chemotherapy first and then should be taken off for the surgery. But some masticator space and pterygoid plate involvement is not an absolute contraindication for the surgery now. But yes, whenever the disease in the pterygomaxillary fissure area or very high in the supranotch, I'll go for a neoadjuvant first and then surgery. Otherwise, infranotch, always surgery first.
Wonderful, wonderful. I think elegantly put, Dr. Rakesh. I think just for the benefit of everybody, I just want to briefly sum this up. T4A involves the cortical bone in the skin, in which always you should consider surgery, unless and of course there is a very extensive soft tissue edema, as was in our patient. You may tend to sort of consider any other modality. In a T4B, again it's a mixed bag. T4B, according to the TNM, they say that you consider non-surgical modality, but that may not be the case for every patient, as Rakesh has elegantly pointed out. Skull-based involvement, encasing of internal carotid, and they say more than 270 degrees, there is some NCCN criteria for inoperability. They say don't operate. But in case of masticator space and pterygoid plates, although they come under the T4B, and a lot of people feel that possibly there has to be some sort of segregation among the T4B. Like, for example, there are some, for example, the Amrita group or Narayan Hridayalaya group, they want to segregate the T4B into class 1, 2, 3 and try to sort of define some of these tumors. So the message that I want to give is not all T4Bs are inoperable. Certain subset, especially the masticator space involvement and the low pterygoid, as Rakesh pointed out, is something that you need to consider surgery definitely at some point of time.
Arvind, one more
Yes,
thing
sir.
to add is extensive skin nodules.
Absolutely, sir. Absolutely. Skin nodules is really bad. Wherever
the more you touch, the more you are going to get into a problem.
Yeah.
Anybody? Yes,
and if tumor is going to the hyoid bone, also involving the below in the neck, that is
Right.
also.
But that's in the neck, Chandraveer. We are talking about in the primary.
This other tumor is extending below it up to the hyoid bone, sir. That is also a consideration.
Yeah. There is some. In fact, because you're coming to that, let me come to this picture. So this was again evidence from the Tatas. I think Kumar's group, right from way back in 2013, they had this sort of publication extending up to the zygoma and extending up to the hyoid. How many of you all actually consider this as borderline operable? Like, I just wanted to have a show of hands from, or possibly some idea from everybody else. And this was the Tata paper. They had put about 4 criteria of borderline operable. They said that it is not that these patients are resectable, and this decision was taken in a multidisciplinary tumor board. Anybody can chip in?
Yeah, I think what you're saying is right. Rakesh and me are saying that you should call it borderline operable and look at some modality of treatment. Don't give these patients up.
Fine. And if you go by the CT scans and just have picked up to this is only a masticator space involvement, wherein you see where the pterygoids are all clear. So this patient, you should definitely be able to operate. So NCCN would actually tell this is a T4B. It does not really mean it's inoperable. It's a masticator space T4B. It is operable. Again, if you see in this particular case, it is going on to the skull base, eroding the skull base a little bit, clear inoperable. This is again T4B. So there needs to be some sort of classification among the T4B, and that is what people are telling. Now, again, coming to this particular gentleman, what are the takers? Like, upfront surgery, neoadjuvant chemotherapy, any takers for chemotherapy, radiation, supportive care?
If I may add, I think this looks quite pretty advanced. So I think, we would prefer, downstaging with neoadjuvant chemotherapy with probably a triplet with docetaxel, cisplatin, and 5-FU, maybe 2 or 3 cycles of chemotherapy treatment. And then the thing is, this patient would have a re-imaging done. And then the thing is, assess in the MDT whether the thing is, is this resectable or not.
Perfect. And everybody else, any other opinions from anybody else? Perfect. I entirely. Okay. The other question, I think it's I want all the madams to come into this, is how easy or difficult is to give TPF in a community practice, or depends. Like, if you're in an institutional practice, I guess things are much better placed. But in a community practice, just please let us know how the issues you face with administration of the TPF.
And what is the solution for it?
Yeah, absolutely. I think this is entirely for you.
So there are actually lots of issues for TPF. It's not simple to deliver. So one thing is we need the central line access because of the 4 days infusion. So central line access is always difficult. It increases cost also. Sometimes we have to insert port or any other central line. And second most important thing is 5FU infusion related toxicity, because at least means so many patients I have seen that patient gets MI, stroke during the, so it's before surgery only when we are trying for curative intent. So these two major other febrile neutropenia means it's a routine and it's not a problem for me, but these two exercises I have lost patient in MI also. So it's a very guilty from our side, yes.
Absolutely. Any other thoughts from other madams in the panel?
So basically, DCF I would only consider in a young fit patient, well educated, knowing about the toxicity, having a healthcare access around him, so that immediately he can go if there is a fever, if there is any issue, and reasonable good education, very important, because DCF requires acute care many a times. The patient should not ignore symptoms. There are certain unusual toxicities, hyponatremia happens, very different things can go wrong. So DCF is a toxic regimen. I would not be comfortable using it in community. I would be comfortable in using it in a educated young fit patient who knows about the toxicity, knows about the risks. And central line and everything is an issue, but it's one of the best regimens. Let me tell you.
So
but
my question here is, I'm sorry, overriding Arvind.
Yes,
What is the solution?
Yeah, absolutely, sir. I was actually going to ask that only.
Sir, the solution, unfortunately, the solution is we cannot replacing docetaxel with paclitaxel, like that is one thing which you sometimes maybe tried. Some evidence that neutropenia etc is somewhat less, but
can you double it? Can you give
doublet? So sir, if the patient cannot be given docetaxel, cisplatin and 5FU, my regimen of choice is docetaxel and cisplatin with GCSF support. So that is what I do in a general hospital or a government hospital.
Great.
Sorry for interrupting, but there is only 4 minutes left.
Oh, okay. Oh my God, time seems to fly. Anyway, we have discussed a lot of things, but then just to
yes,
Arvind, if you have got only 4 minutes, what will be the margins of your new surgery?
Yeah, basically, this is a very important question.
Yes, sir. I think I have this questions. Yeah, I think margins, like this gentleman received neoadjuvant chemotherapy and was for surgery. How do the surgeons assess the margin intraoperatively? Is frozen sections use and choice of reconstruction for this gentleman? I think any takers for this?
So I'll just say a few words.
Yeah.
When I was in Tata, we were running a study in neoadjuvant chemotherapy for T4B tumors, where we used to mark them before chemotherapy and then again assess after the chemotherapy at the surgical table. So when we took the margins according to the earlier margins, that was the initial margins.
Yeah.
But when we compared the shrinkage and find out in the two margins which we had pointed out and the earlier margin, there was satellite nodules. So shrinkage in oral cavity cancer doesn't happen concentric wise like in a breast cancer or something. So it's satellite nodules at different areas. So then it's more prudent that we take the previous margins, what we have decided before the chemotherapy. So that seems to be the answer till now, but I'm not sure.
Do you use frozen section intraoperatively to guide your margins? And that's an important aspect.
Yeah, I use regularly.
Great. Yeah. So I think to answer the question of margins, 5 millimeter margin rule holds good whether it is upfront or post neoadjuvant. Extent of margins following induction chemotherapy, as in this case, remains controversial. You don't really know. But the thing is, as you rightly said, concentric shrinkage does not occur in any cancer for that. Even in breast cancer or in head neck or any other cancer, we don't really expect a concentric shrinkage.
Arvind, here the point to be made is that it's different what you do it in buccal mucosa and different if you do it in tongue. So if you're giving neoadjuvant to reduce volume in tongue, then your focus has to be different, because here you're trying conservation. And buccal mucosa you're looking at comparability. So there are two different ball games which are at play out here. And although frozen section helps. I also do in some patients. But I think it's been shown that it really doesn't add. Ultimately, as a surgeon, one has to think that you need 1 centimeter and go down with 1 centimeter. Don't wait for a frozen to tell you something as a surprise.
Great. I think exactly the points that I had in my slide. Frozen section guided margin revision, and this is for upfront surgery. It has not conclusively shown to improve local control. And a gross examination of 7 millimeters, and this was Pankaj's paper a couple of years back. Of course, this was not in the neoadjuvant setting. This was in the upfront setting. So it's a cost-effective way of going about the margins.
Yeah.
And of course, you'll have to do a block resection, ink it, sample it well. All these issues are there. And like, for example, in this particular patient, I would want to ask the radioms, if it continues to be a T4B and extensive PNI was there in this particular patient after surgery, what would be the adjuvant treatment be? Would it be adjuvant radiation therapy alone, or would you want to add, like this gentleman had received 3 cycles of TPF, we operated margin negative, but still tumor was extensive tumor, and extensive PNI was also there. So what would your adjuvant treatment be? And this is what do everybody follow in their regular practices? Only a radiation or add chemotherapy, or when do you add chemotherapy?
This patient is definitely at quite a significant risk of having it's extremely high chance of locoregional relapse. So I would definitely, advocate looking at the clinical picture that you've shown right at the beginning. This patient would definitely require radiotherapy treatment and adjuvant chemo radiation treatment as well.
What chemotherapy? What chemotherapy?
If TPF has been given,
TPF has been given. TPF has been given. Yes. This is that's a very important.
Carboplatin can be used. Carboplatin can be used.
Right. Any other thoughts of anybody? How do they go about in their regular practices? Because this is something of a very common scenario that we see.
Quite frankly, if no adjuvant chemotherapy and after that the margin negativity has been achieved, I would still go for chemoradiation. That is number one. Because as Dr. Rakesh also mentioned, there are a lot of satellite nodules in between. So that might be positive. You never know that something might have been missed. So I would personally, in most cases who have received neoadjuvant chemotherapy, I would advocate adjuvant chemoradiation.
No, I agree. Yeah. Chemo, but what chemo? Because you have received, patient has received TPF.
So again, if the patient has received TPF, the tolerance to cisplatin is quite low. It's not very high, but still my preferred option would be to try weekly cisplatin only, rather than carboplatin.
Cisplatin only. Okay,
yeah,
great.
That would be my choice.
Again, there is absolutely no consensus on this, because if you see the tax 323 and 324, they were actually non-surgical candidates. So we don't really know. And in the tax 233, they gave only radiation in one arm, chemoradiation in the other arm. What we tend to do, I would let you know, that we tend to give in such high-risk patients radiation therapy and carboplatin for these particular patients. But then it is open, people can actually give based on the tolerance of their patients, either radiation therapy or consideration of some form of chemotherapy based on the fitness for these patients. And the final thing, any thoughts?
Only 3 minutes. 3 minutes exceeded, sir. Already exceeded.
Okay. And the final take home, I would like to possibly say that in such cases, like in T4A cases, yes, definitely radical surgery upfront. T4B select cases, even radical surgery if possible. In the cases scenario, as I said, possibly consider neoadjuvant therapy and surgery. If you incorporate surgery, you are going to get a long-term cure. Patients who don't respond well to the neoadjuvant chemotherapy or who progress and on whom surgery is not possible, forget cure for these particular patients. And in some patients in which it's like the high ITF in the pterygomaxillary fissure, skull base, internal keratin, these are obviously candidates of non-operative, and you go in for non-curative therapies. I think with that, any other points anybody wants to make? Otherwise, we can wind the panel in the interest of time. I would like to thank the organizers, thank all my panelists for the constructive suggestions, and I hope we have done some justice and given some take-home points to everybody. Thank you.
I think, Arvind, you have covered most of the points that are required in this short time, and it's a topic for a 1 hour. Anyway, thank you so much for allowing us a little bit of extra time. And I thank my co-chairman, Dr. Sudeep Sarkar and Dr. Panda. And thanks to Bharat for having organized and taken us here.
Thank you,
Thank you so much. Thanks a lot.
Thank you.
Thank you for the wonderful
Good afternoon,
session.
Thank you, sir.
Okay.
And I will ask, I want to request my chairperson to ask the next speaker, to invite the next speaker for the next talk on. Our next speaker is Dr. Pratik Tiwari. He will be, yeah.
Yeah, you introduce.
Okay. Yeah. So our next speaker is Dr. Pratik Tiwari. He is a consultant medical oncologist at Jawaharlal Nehru Cancer Hospital and Research Center, Bhopal. He will be talking on targeted therapies in head and neck cancer. Dr. Pratik Tiwari.
Yeah, hi, good evening. And can I have my slide? Actually, can you project the slides from your side?
Sure, sir.
Yeah, thank you. I can see my slides. And I want to thank Dr. Bharat and organizers for inviting me in this session. And my topic of discussion will be targeted therapies in advanced head neck cancers. And next 10-15 minutes, we will discuss upon targeted therapy. So targeted therapies are those molecules which actually, yeah, I can tell you when we can move the slide. So targeted therapies, targeted agents are those molecules which specifically bind to a target, and after binding, they will change the tumorigenesis and they will produce a halt of tumor or enhance apoptosis. And by that, we expect that they are less harmful and they will produce effect without side effects. Next slide. So we do have so many targets in head neck cancer, but as of now, we only have molecules which can alter and produce a significant response is EGFR and PIK3, which is actually investigation now. But I think by next year or next 1.5 years, we will have alpelisib in hand, which can be tried in head neck cancer. Next slide. So we have these four molecules: EGFR inhibitors, insulin-like growth factor inhibitors, VEGF inhibitors, and RON receptors. So these four, but our area of interest is EGFR because we have only these molecules in hand. Next slide. So EGFR group of family is actually, there are four type of receptors, 1, 2, 3, 4, and they will produce their effect when they homodimerize or heterodimerize. So only after dimerization of these receptors, they will produce their effect. Next slide. This is a EGFR receptor, and you have a ligand binding site. You have a in transmembrane area. You have a cytoplasmic domain, and then you have a kinase domain. Next slide. And the downstream pathway, they once they dimerize, they will produce effect by PIK3CA, mTOR, or AKT, or JAK-STAT, and they can produce their effect by RAS, RAF, MEK kinase pathways. So these are the three main pathways, downstream pathway, by which they can produce their effect. Next slide. So we can inhibit either by external or extracellular domain, which is our molecules, which we will discuss: cetuximab, panitumumab, and other receptors. They are actually maps which can inhibit or which can bind ligand binding site, and by that they will prevent ligand binding, and they enhance receptor internalization, and they inhibit their homo or heterodimerization, and by that they will produce their effect. Next slide. So EGFR is actually expressed and it can be detected by IHC, but no one is doing routine IHC for EGFR expression. And most of the time, more than 90% of the head neck cancers, you can find EGFR expression. It can be overexpressed by more than 90% of the patient. Next slide. So it's a worse prognostic factor, and you can have it. This pathway can be actually active in other cancers also, like colorectal cancer, lung cancer, breast cancer, or sometimes glioblastoma. Next slide. So, what are the therapies? So, for EGFR inhibitors, we have cetuximab, panitumumab, and salutumumab, geftinib, which is actually tyrosine kinase inhibitor. They will produce their effect. They can enhance the activity or sensitivity to radiation, and they will produce their effect by inhibiting cell proliferation, DNA repair mechanism, and they can promote apoptosis. So these are the main pathways by which they can produce their effect. Next slide. So after binding, MAP cetuximab inhibits their dimerization, and by inhibiting their dimerization, it can prevent the downstream pathways by which tumor is forming and tumor is proliferating. So by blocking that EGFR pathway, it can produce their effect. Next slide. It is approved in colorectal cancer, KRAS wild type. It is approved with radiation in locally advanced head neck cancers, those who are not eligible for cisplatin. And it is approved in palliative chemotherapy in combination with chemotherapy or single agent in metastatic or recurrent head neck cancers. It is investigational in other settings like breast cancer, lung cancer, and pancreatic cancer. Next slide. Side effects, especially it can produce, because it's an foreign protein and humanized protein, it can produce a reaction. Infusion reaction is a common side effects in approximately 40 to 50%. Acneiform rashes can be there because it is a common toxicity in most of EGFR inhibitors. It can produce constitutional symptoms, it can produce diarrhea, it can produce hypomagnesemia also. Next slide. So it is we do not give therapy according to their EGFR expression, and we usually don't check it for EGFR expression also. Uh, Skin toxicity is problematic in some patients, grade 3 and grade 4. For that, you have to modify the dose, or you can give some supportive therapy like clindamycin cream or doxycycline to reduce the toxicity. Hypersensitivity is not problematic. Sometimes it can produce sudden deaths also. Next slide. So this was the initial trial based on which it got the approval. And here the setting was recurrent and metastatic platinum refractory head neck cancers. And in that that cohort of patients, they gave cetuximab and they got response rate of 17% with CR rate of 5%. And median time to progression was approximately in 3 months, and survival was approximately 6 months. So based on that, cetuximab came into the picture. Next slide. And these was the famous trials, landmark trials, extreme trial, in which they combined a traditional 5-FU cisplatin with cetuximab against cisplatin 5-FU in recurrent or metastatic head neck cancers, and they have a significant response rate of approximately 35%, and they have a significant PFS, which was 2 months bigger, and they have a significant median overall survival. The side effects are more in cetuximab arm, and we can see more of febrile neutropenia in cetuximab arm. We can see more of rashes in cetuximab arm. Next trial is also a combination with cisplatin, and here you can see a significant response rate without any overall survival or PFS benefit. And here also cetuximab and combination arm was more toxic. Next slide. This was in combination with radiation, and here they gave combination of cetuximab and radiation, and the other arm was only radiation. And the group of patients are locally advanced head neck cancers. Next slide. And the group of patients are actually well balanced, and here you can see if you can find in this table, there are three groups of patients: oropharynx, larynx, and hypopharynx. These are the two groups. Most of the patients are stage 3 or stage 4, although they have stage 1 or stage 2 patients also. Next slide. Both the groups are well balanced. Next slide. So results, you can see that the local regional control is more in favor of cetuximab arm, cetuximab with radiation, and they achieved approximately 24 months of locoregional control, which is 10 months higher and significant. They have progression-free survival benefit, and most of the patients of oropharynx and larynx group, they did well, although hypopharynx, it is not significant. Progression-free survival was better, overall survival was better. Next slide. So these are the graphs, and you can see that clearly radiotherapy, if you add cetuximab, it will increase your survival, and that's how it because it's a radiosensitizing agent. Next slide. And you have a better overall survival also, approximately 49 months versus 29 months, which was significant. Next slide. So results and safety. Most of the patients tolerated cetuximab well. Only some patients, because of hypersensitivity and grade 3 rashes, they discontinued, and otherwise it will not enhance radiation toxicity. Next slide. Only toxicities are rashes, sometimes diarrhea, hypomagnesemia, and infusional reaction. Next slide. What are the limitation of that that landmark study is actually the other arm was only radiation arm. Ideally, they should have a radiation with cisplatin. So that was the not standard arm, and they have different RT regimes in different patients, and results of different region are not specific. It is actually, we can see that it works well in oropharynx and larynx, but it is not working in hypopharynx. They don't have quality of life data later on, and later complications they have not commented. Next slide. They have 5-year update also, and 5-year data also shows a significant benefit with combination of cetuximab and radiation, and overall survival is approximately 45 months in combination arm versus only RT, it is 36 months with hazard ratio of 0.49. Next slide. Other trials are also ongoing, and they are phase 2 trials which combined cetuximab, cisplatin, and docetaxel. Cisplatin, cetuximab, or docetaxel, these are two arms, and it favors docetaxel also, but it is ongoing trial. There is no mature data right now. So there are different phase 2 trials are going on, but they don't have right now a mature data or significant results. Next slide. These are also ongoing RTOG trials which are ongoing and they don't have mature data right now. Next slide. So following that landmark trial, which was RT versus RT and cetuximab, cetuximab was approved with combination with radiation. Next slide. Other agent we have panitumumab, which is completely human antibody, and the trial name was Spectrum, and it was combined with cetuximab, cisplatin 5-FU, and panitumumab. And here you will have a better PFS, but you don't have a significant overall survival benefit. It is combined in locally advanced head neck cancer, and it is actually they are doing a trial against cisplatin RT versus this RT and panitumumab, and it is ongoing trial. This data yet to come. Next slide. Zolatumumab, I don't have much experience of this compound, but they are trying in head neck cancers, and it can be tried. It is a humanized antibody, anti-EGFR antibody, and by trying that as a single agent also, you can have a PFS of 26% versus 7%. So it shows activity. Overall survival is not significant. Other molecules which we use here, and I also use, is nimotuzumab, and we have data from Tata also. And there was a study, BEST study, which shows some improvement in overall survival. Next slide. So that was the study. Here they used it in stage 3 or stage 4 head neck cancers. The 4 arms was nimotuzumab with RT alone, nimotuzumab, RT, and cisplatin, RT and cisplatin. These are the 4 arms. Next slide. A number of patients are not that great, but we have a small cohort of patient, approximately 20 patients in each arm. Next slide. So results shows that the combination arm, which contains cisplatin, radiation, and nimotuzumab, they did far well as compared to against other group of patients. So basically, 2 groups did well, which is nimotuzumab with radiation or nimotuzumab, cisplatin, and radiation. Next slide.
Sorry
So-
to interrupt, but the time has already over. If you can conclude.
Okay. So this was the data, and they shows the survival benefit with radiation and nimotuzumab. Next slide. So basically, these are the molecules which can be used, and cetuximab only molecule we can have overall survival and PFS and response rate. Next slide. Other molecules which are investigational, like jeftinib, barlotinib, we have a data from Tata study, a metronomic study, and in which there was a survival benefit against supportive care. Only that study we have right now. Otherwise, jeftinib and barlotinib, they are mostly investigational. Next slide. Next slide. Next slide. So other targeted molecules are insulin-like growth factors, and I don't think this fujituzumab is showing any activity right now in any randomized trial or phase 2 activity. Next slide. VEGF also, it's a targeted molecule and targeted pathway, but there are trials. Next slide. Which is going on. Next slide. Which is in phase 2, and we don't have much or any interesting data coming up from bevacizumab part. Next slide. So it is only 30% active, and I don't think you can add and you will have any beneficial effect right now. Next slide. Small molecules. Next slide. Apart from setiranib, other molecules are investigational and they don't have any response rate right now. only this molecule is having 25% response rate, but we need more data. Next slide. Next slide. Next slide. Other downstream pathways like JAK-STAT, PI3K, as I told you in the beginning, that alpelisib is investigational, and we may have alpelisib in metastatic setting in 1 or 2 years after that. Next slide. Next slide. So these are different molecules which are investigational, and we don't have right now any molecule which is approved for use in head neck cancer. Next slide. Next slide. So to summarize or conclude, we have only cetuximab or panitumumab and biomab in our hand, which is showing some activity, and that can be used in combination with chemotherapy or radiation. We need more data and more molecules which can be active later on. Over 1 or 2 years, we can have more molecules because so many things, studies are going on. By this, I can conclude my talk, and thank you, organizers, for inviting me.
Thanks for a very elaborate talk. Now I would like to request Dr. For the expert comment, Dr. Piyush Bajpai.
Thank you, Dr. Bharat, for inviting me, and thank you, Siddharth. Well, good evening to all who are attending this. It was a very wonderful panel discussion by Dr. Arvind sir, and Dr. Prateek gave a wonderful talk on the targeted therapies available. So I would, Dr. Arvind sir has clearly laid down the take-home points, and I would not go into that. But Dr. Prateek has also laid down his take-home points very well also. So he has said that in 2006, the Bonner paper has shown that on the basis of which cetuximab got approved, there was an overall survival. We were looking for the replication of such a study, but unfortunately, what we saw that this sort of the overall survival what we got from the Bonner paper, we could not get it when we tried to add cetuximab to cisplatin, because the proof of the principle did exist that you would get better responses and better efficacy, but it did not happen. So also there is a paper on HPV positive and patients who are getting cetuximab and RT, and you do not get those survivals. So yes, cetuximab is in practice for when you cannot deliver cisplatin due to majorly renal issues, and that is what is in my practice. In 2008, Dr. Prateek rightly told the Vomakan paper, where it has been used in the locally advanced and metastatic setting, the extreme trial. Yes, this has been also in practice. There has been a single agent activity, as Dr. Prateek told, but then that's a very low 8 to 17% of response rates that you can get with cetuximab. Nimatuzumab, Dr. Patil's paper last year probably is one thing which has led to adoption and practice, and quite relevant when you are looking at now that the weekly concurrent is quite equivalent to the 3-weekly one. So you can actually add on this particular molecule and get good results. So with this, I would like to thank for this opportunity. Thank you, Dr. Bharat.
Thanks a lot, sir, for giving the expert remarks. Now, I would like to quickly go on to the next session of gynecology cancer. So I would like to invite our esteemed chairperson, Dr. Rajiv Das. He's a surgical oncologist at Mumbai. Dr. Nagraj Kulgol, he is a chief radiation oncologist at Mumbai. And Dr. Bhavesh Parikh, he's a medical oncologist at Ahmedabad. So I request our chairpersons to invite our moderator for the next session.
Hello, can you see me?
Yes, sir.
You are visible.
Hi, good evening, Dr. Nagaraj here. Yeah, so we move on to the next session, which is the gynec oncology, and it's exceedingly important. And we're going to discuss the recurrent ovarian cancer, which is very recalcitrant tumors. And there are quite a few interesting surgical and non-surgical options. So we have an esteemed panel, and may I invite Dr. Amit Bhatt and his panel to discuss the topic. And I'm sure Dr. Amit Bhatt can call his panelists and will initiate the discussion. After the panel discussion, maybe we can have some questions from the audience. And then we have the second session, but that's one on the bevacizumab. So let's start with the panel discussion. Dr. Bhatt, Amit Bhatt.
Dr. Amit Bhatt.
Good evening. Ravindra, can you just share the slides, please?
Sure, sir.
So
Certainly.
till that time, I will call on our panelists. So our panelists are Dr. Gaurav Gupta, Dr. Sampada Desai, Dr. Richa Bansal, Dr. Rohit Ranade, Dr. Vijay Sharnagat, Dr. Viraj Lobrekar, Dr. Saurabh Goswami, and Dr. Akash Tiwari.
Yes. Thank you so much, Siddharth. Are all the panelists there?
So Dr. Navrekar could not join due to some emergency. All other panelists are there.
Excellent. So we have a couple of surgeons and rest medical oncology heavy panel. So let's just get on with the next slide, please. So today I'm not going to discuss any case. We are just going to, as the topic says, we have to form a treatment protocol at the end of the discussion at 30 minutes. So we'll just talk about the treatment protocol, how we are going to approach recurrent ovarian cancer. So let's go start with the medical oncology. Akash Tiwari, what is the most important point that you're going to assess when a patient of recurrent ovarian cancer comes to you? One of the most important points. Dr. Akash, are you there?
Hello, am I audible, sir?
Yes, you are audible.
Points that
maybe 1 point and then the rest. There are 4 medical oncologists, so everyone can take one point.
Sir, biochemical relapse versus anatomical disease, if it is visible or not, and the platinum-free interval and toxicity from the last cycles are the 3 important points that I would assess.
Dr. Gaurav Gupta?
So symptom burden, or rather disease burden, time to relapse, condition of the patient, I guess, and the volume of disease which is recurrent.
In your practice, Dr. Vijay Sharnagat, in your practice, do you routinely rebiopsy? Is there any indication for rebiopsy if the patient comes with a metastatic?
No. I am not performing rebiopsy. Yeah.
You're not
I'm not considering.
Any other medical oncologist who does a rebiopsy, maybe for an NGS or something like that?
No, not for an NGS, but I had a couple of cases where I got a liver mets quite early in the disease course. I mean, it was like 2 years down the line and she had a liver recurrence. So at that point of time, I did a liver biopsy because it's unusual for ovarian cancer to so quickly recur in a visceral site instead of the abdominoperitoneal sites.
Yes. And what is the most preferred imaging modality which you use in practice? Dr. Richa Bansal. Dr. Richa is there? Dr. Richa? Dr. Akash, you can take the question if she's not there.
We get a CT done, sir.
Any people for PET scans? Anyone does PET scans?
PET scan only if a CT does not show the disease that has been met.
Can I make a point, Dr. Amit?
Yes, please.
Yeah, so I think CT is a good modality, but it should be done both with an IV and oral contrast. But sometimes PET works out logically or logistically more better than getting a CT abdomen, pelvis, and thorax. So even a PET scan, but that should be with an IV as well as an oral contrast.
So I would beg to differ. I don't think we need a CT thorax for ovarian cancer recurrence most of the time.
Okay, so most of you are doing the CT. The next slide, please. Next slide, please. Yeah, so these are some important considerations. One thing let us just focus on the patient part, prior toxicity. Dr. Akash, can you take this? How does prior toxicity history help you in discussing the patient?
Most of our patients would in first line receive paclitaxel, and that has been the practice. So the most important toxicity that we look at is if there is a residual neuropathy, and if we can challenge them with paclitaxel again. That is one thing that we see. And then how an individual has tolerated previous chemotherapies. Hypersensitivity reactions to carboplatin earlier is another history that is important and we like to take. If he's been on multiple lines of therapy, probably a renal dysfunction.
We'll come to that. We will come to that. Next slide, please. So, Dr. Gaurav Gupta, any patient of ovarian cancer where you're not going to treat? Is that scenario today? So you see a patient and say, no, I'm not going to touch this patient. Is there a scenario today in today's world if that happens? Dr. Gaurav?
Hello, am I audible?
Yes, you're audible.
Yeah, so low volume disease, asymptomatic patients, I usually defer therapy in such cases.
Absolutely. We just spoke about biochemical relapse. Can you just next slide, please? So
so basically,
this is a very common thing
that
this is a very common thing that comes. So if there's just a biochemical relapse, what are you going to do? How long are you going to wait?
So as long as the patient doesn't get symptomatic, or sometimes the patient themselves start panicking that the CA-125 level is now 100 or 150 or 200 and insist on therapy. So that would be some shared decision where I would start. Otherwise, I will wait. I'll prefer to wait till the patient gets symptomatic or has some unusual or heavy burden of disease on scanning.
Dr. Richa Bansal, is she there? Dr. Vijay Sharnagar, do you agree with Dr. Gaurav Gupta? We'll wait for symptoms.
We can wait for the symptoms. Till then, we can start like tamoxifen. So tamoxifen therapy can be considered for the serological relapse patients where we can get like little progression-free survival, like in the weeks, 4 weeks or 8 weeks. We can consider.
So, do all the medical oncologists concur that you won't scan the patient with a CA-125 say of 1,000 if the patient doesn't have any symptom?
So I did say that until unless the patient has a large volume of disease on imaging, so that I guess that includes those subset of patients. Those probably will be started on therapy.
So if a CA-125 is rising on the first day, then you would do a scan and see the disease burden?
Yeah, usually I do.
Yeah, okay, perfect. And how frequently would you call the patient back to your OPD?
So that depends on the speed of rise of CA-125.
So how frequently would you do the CA-125?
So not less than a month or so, at least 4 to 6 weeks, at least.
All my medical oncologists agree with that, say monthly CA-125s to monitor?
So initially, probably in a shorter duration, and once we get to know what the rate is, and there is no evident disease, probably in a 2-month duration or spacing out.
Okay.
That is
next slide, please. Next slide. Next slide, please. Yeah, so there's data for that. There's no point in treating asymptomatic patients with CA-125 rise. There was a median delay of chemotherapy by around 5 months, and that really did not affect the overall survival. Next slide, please. So yeah, my surgical oncologists come in here. Before that, medical oncology, Dr. Akash, when would you refer this patient to a surgical oncologist?
So an individual who had a relapse, who is a platinum-sensitive relapse, single-site disease, I'd refer them. Preferably, if the treatment-free interval has been around 2 years, only one site of disease, fit patients, refer them for a surgery.
Dr. Sampada Desai, is she there?
Yeah, I'm there.
Yeah, doctor. So, does surgery make a difference in the overall survival in recurrent cases? Straightforward.
Yes. If we get only thing is that we have to select our patients properly. If we get R0 resection, it does make a lot of difference. Especially now we have a data with Desktop 3 trial wherein there is a 12 months benefit if you get a R0 resection.
Exactly. Next slide, please. Yeah. So this is very important, and the take-home point from this is that if there is a complete resection, then only the benefit was seen. If there's not a complete resection, the benefit was not seen. Dr. Anade, how would you assess your patient for surgery at this point of time when the patient comes on recurrence? Because prior to surgery, how would you know that are you going to completely resect or not? Next slide, please.
first is important is the performance status of the patient, as other panelists have also stated. And then for resectability, we would do some imaging, usually CT, a 64 or a 128 slice CT with an IV and oral contrast is good enough to assess the resectability. And most of the times it is CT which will tell you whether it is resectable or not. And again, there are going to be some surprises, so that you have to be ready for that as well.
Any scope of diagnostic laparoscopy? Would you do you do it in practice?
It's a good tool in certain situations, but usually what would happen is this is a lady who would have already got operated first, so we expect a lot of adhesions also. Usually diagnostic laparoscopy might not help in these scenarios. Sometimes it can diagnose gross peritoneal disease, subcentimetric peritoneal disease, which a good CT might miss. But most of the times, unless you release those adhesions, you're not going to find tumor sanctuaries there on diagnostic laparoscopy. So usually in recurrent setting, it is little less useful, but in primary borderline resectable, it is a very good tool to assess.
Next slide, please. This is
So,
when the
hello.
Yes?
Can I ask a question, please?
Yes.
Yes, please. Please go ahead.
Yeah, it's to my surgical colleagues. Do you see any role of PET scan in this situation to assess the disease? Pre-op. I mean,
Not
pre-op.
exactly. I mean, hello, Gaurav?
Yeah, hello.
Yeah, once you probably know that there is a recurrence, which a CTA and also your CA125 might suggest. Probably PET scan doesn't have any added advantage. Primarily, since most of the PET machines have a 16 or a 16 slice CT, while I would more prefer on a standard CT with a 64 slice or a 128 slice. The pickup rate and the resectability is much better decided on a standard CT as compared to a PET CT.
Great.
I mean, PET CT is not advantageous, maybe.
Yeah, because many times I have referred such patients and I have got the surgeon telling me to get a PET scan done. So that's why the question comes from.
Probably mostly is that for metastatic status, if not
Yeah,
done.
maybe it is. That's why I said probably it's a single investigation which you can get instead of
looking at this GOG data now. Inclusion in this GOG data was all those patients whom the surgeon felt that complete R0 resection could be done at the onset, and out of that only 67% could undergo the R0 resection. Unfortunately, rest did not go the resection. And finally, the data, those who underwent those resection who were not R0, there was a 29% increased risk of death. So this is a pretty high by risk of death. So both my surgeons, Dr. Sampada and Dr. Anade, how would you improve your pickup rate in this kind of case? What would a strategy to be sure that you don't miss or you don't land up in those 1/3 of the cases where the resection is not as futile? Because this is a very thin wire we are walking right now.
Yeah. So it's a very interesting. I mean, it's a very practical question probably, because this is primarily because if you look at both these trials which have come in secondary setting, one is the GOG trial and one is the recent Dextop 3 trial, both have shown contrasting results. The GOG trial did not show any difference in survival, while the Dextop 3 showed a significant difference in survival with surgery. Now, I think the selection criteria in Dextop was much more rigid. I think performance status is something which is very important, and presence of ascites is something which is very important. If there is ascites, even though your CT scan doesn't show that there is disease elsewhere, you will always find disease somewhere in the setting of ascites. Usually, ascites is something which you should maybe avoid doing surgery. That is what is my take on it.
Next slide. Yeah, please go ahead.
Yeah, and ultimately, it again you need to you should be ready for surprises. Even though there will be places where your CT will not pick up the disease, but a thorough exploration of the abdominal peritoneal cavity is something which is important.
Absolutely. So there are 3 or 4 the European Gynec Association. These are the 4 things. If there's a short disease interval, there is a lot of intraperitoneal carcinomatosis, ascites, and drug resistance. These are the 4 criteria where they said should not operate. Intraperitoneal, we'll talk about HIPEC in a minute with intraperitoneal carcinomatosis. Next slide, please. So, Dr. Akash, how do you look at your patients when they come to you with recurrence? This is a classical platinum sensitivity, and how do you look at them?
How we do it, as we had said, we look for the platinum free interval. 6 months is the standard definition. Honestly speaking, I'm not very strict with it. So if it is say 5.5 months versus 6.5 months or 7 months, I do give them platinum. If they're actually significantly less, say 5 months, less than 5 months, I treat them as single agent, as a platinum resistant disease should be. So take a cutoff of 6 months, not be rigid with it. That is the formula that we use.
Next slide, please. Dr. Gaurav Gupta, why is this platinum sensitivity so important? Why are you medical oncologists obsessed with the platinum so much? Dr. Gaurav?
Hello. Yeah. Sorry.
Yeah.
Sorry.
So,
yeah.
So why are we?
So what was the question again?
Yeah. Why are we medical oncologists obsessed with the platinum? So why does platinum make such a huge amount of difference?
So yes, basically, once you develop platinum resistance, the response rates to all the therapies, it goes down to less than 10%. And patients who are partially sensitive or sensitive to platinum, they do have a better response rate, better outcomes, even with combinations also. So that is probably the reason that we are so much focused upon the time to relapse.
My other two panelists, Dr. Richa Bansal and Saurabh Goswami, are they there? Are they there? We'll just next slide, please. We'll just go ahead.
And probably there comes the question. I was actually reading the chat box. There was a question about BRCA testing. So there comes the importance of time to relapse.
Yeah,
if you have a patient who's okay, fine.
Yeah, we're going to talk about BRCA a bit. Dr. Sharnagat, because platinum resistance is so important, is there any way that we can really predict? Do we do it in routine practice? Do you do it in practice to check if your patient is platinum resistant or not?
No, routinely we are not checking for that thing. So we'll come to know after maybe giving therapy, and when patient get relapse and recurrence, only then that case we come to know. We are not doing any special test for that.
Among my medical oncology colleagues, any people fond of NGS trying to see any abnormality, predict platinum resistance beforehand? Anyone does it in practice? Dr. Akash?
No, I don't.
Next slide, please. Yeah, so when we talk about the platinum sensitive disease, we really have a lot of partners to go along with platinum. So how would you, Dr. Akash, how would you choose your partner of platinum?
So how I choose it is the last drug given, the response and the toxicity to that drug. Most of our patients would have received paclitaxel earlier. So depending upon how much the duration has been and what the how much neuropathy the individual developed, I choose partners. Usually in the second line, if the patient has received taxane plus carboplatin or platinum sensitive disease, I'll go for lipodox or cisplatin as a partner with a drug. As a practice, no specific reasons. But I look at the toxicity as well as the duration since the last therapy.
Dr. Gaurav Gupta, any specific comments on this? Dr. Gaurav or Dr. Vijay Sharnagat, both of you?
Yeah, so I usually prefer to discuss this thing with the patients regarding toxicity response rate. That doesn't matter. So those patients who doesn't want to lose like hair, so I prefer liposomal doxorubicins. Those patients who has like grade 2 neurotoxicity, then also I prefer to go for like liposomal doxorubicin or gemcitabine as the partner agent. Otherwise, all patients I consider to go for like carbopacly, where neuropathy is not there, because overall survival is little better with the paclitaxel when we use in the second line.
Yes, next slide.
When we compare,
the problem here is sometimes the comorbid illness like diabetes or previous coexisting problem also should be considered when we consider the partner for the plating.
Absolutely, Bhavisa. So nice to see you again.
Apart from that, there is another issue. Gemcitabine is logistically difficult because the patient has to come on day 1, day 8. PLD patient can come 4 weekly, great, and paclicarbo 3 weekly. So that's another consideration that runs through my mind when I choose the partner.
I think the treatment protocol, because none of the drugs are better than the other, so you can just have a discussion with the patient and then Obviously your personal preferences are there, but our discussion with the patient will help you finally determine this. Next slide, please.
Especially in this COVID era, because the patient have to come far. So we have to discuss also in such type of webinar.
Any takers for single agent therapy? Sick patients, my comorbid patients, like Dr. Bhavesh sir said, single agent, anyone does single agent therapies? No one has.
Generally the doublet is the better choice rather than single.
Yeah, sometimes I consider for single agent when there is like hypersensitivity reactions to the carboplatin, maybe even with the platinum sensitive patients. So we have to go alone, like with gemcitabine, liposomal doxorubicin in that case.
Next slide, please.
Sorry to interrupt, but only 2 minutes remaining.
Okay, we'll just quickly run through. So next slide, please. Just go ahead. Yeah, this is very important. Again, my surgeons come in. After 3 cycles, suppose this patient has excellent response, say on a CT scan, and has some peritoneal disease. So what is this role of HIPEC? When would you say that, yeah, this is the right patient for HIPEC? Dr. Anade and then Dr. Sampada. Both of you comment, please.
See, to be frank, there is no evidence, there is no level 1 evidence to offer HIPEC in a recurrent setting, especially now with the Desktop 3 trial coming in, where they have said just good CRS is something which gives you a survival advantage. So I really have my doubts, though technically I am still offering patients HIPEC in my practice in this scenario. But with the Desktop 3 trial, I think we should all give it a thought that is actually HIPEC making a difference, or it's a good CRS which is making a difference. CRS, yes, definitely it should have a role, but whether HIPEC has any advantage to offer over standard intravenous chemotherapy in this situation is something which we need to look at.
Dr. Sampada?
Yeah, actually there was a single trial that was this setting of like patients which were upfront inoperable, we give them patients who are upfront inoperable, we give them 3 cycles of chemotherapy because they had lot of peritoneal disease burden. Whether HIPEC will make a difference, the question is still not answered, but we do offer them in this setting. But the patients who undergo direct cytoreductive surgery, like a single site disease or a carefully selected patient which does not require chemotherapy to downstage this disease, in this case might be only CRS is a good answer. We do not offer HIPEC in these cases, but patient who had initially lot of peritoneal disease burden and we are cytoreducing them after 3 cycles, we are. And there was a trial in 2015 published, which was a very small trial, actually phase 3 randomized trial, which did show overall survival difference with offerings of hyperthermic intraperitoneal chemotherapy, but that was a very small trial involving 60 patients.
This is the data, and then this really put on HIPEC on the radar for everyone. But I guess over the last 5 years, the HIPEC has again gone a little back foot, and then we are again concentrating on a good surgery rather than using chemotherapy as add-on. So I think right now, good surgery, a good assessment of surgery, and a complete cytoreduction is the key for a long survival. Let's just skip on to the slides. Next, please. Next lead. Next. There's an algorithm. Just go ahead. I'll tell you when to stop. Go ahead, please. Go ahead, please. Yeah. So as we talked, we had to make a protocol at the end. So bevacizumab, we have a lovely discussion on bevacizumab after this. So I won't go into bevacizumab in detail. But bevacizumab, when would you consider, Dr. Akash? All patients?
Sir, in platinum, in relapse setting, I offer in all patients. In patients with who are platinum refractory, but yeah, I offer to all patients.
Dr. Gaurav Gupta, PARP inhibitors after the treatment, maintenance PARP?
Yeah, if the patient is, especially if the patient is BRCA positive, I would probably do that.
Yeah. So, and if the patient is BRCA negative, then you won't be giving PARP inhibitor?
So yes, I usually don't give in that setting.
Okay. Dr. Vijay Sharnagar, do you agree with this? Dr. Vijay?
Yeah. I agree with this thing. Yeah, I will not consider maybe when patient is BRCA negative, although there is like a little benefit with this molecule, even
Dr.
with that
Akash?
thing. Yeah.
No,
Dr. Akash?
not in BRCA mutated.
Okay, so just next slide, please. So there is good data to suggest now that even in non-BRCA mutated patients, PARP inhibitors really work. Not as good as BRCA, and US FDA and the EMA both have approved PARP inhibitors for using even in upfront setting, as well as maintenance setting. Rucaparib is now approved in maintenance setting in the recurrent as well, and PARP maintenance is there. So irrespective of our BRCA status, the guidelines say that yes, PARP inhibitors work.
Dr. Amit, actually in this setting, we have a better option of using bevacizumab. It is well tolerated.
Absolutely. The PARP inhibitors for maintenance therapies after bevacizumab, or a patient who has not given bevacizumab for
BRCA negative
toxicity.
patient, I think bevacizumab is a better option than giving.
The point to be conveyed is BRCA mutated or not mutated, PARP inhibitors are approved right now. So that is the point to be conveyed. Yeah. PARP inhibitors can be used irrespective of your BRCA status. It's not only that BRCA, even if the patient is BRCA positive, then only you're going to use. They're costly, so mostly in practice we don't use, but yeah, that is it. Next slide, please.
They have worse side effect profile also as compared to bevacizumab.
Maybe not, because olaparib, now we are using olaparib available in India for a lot of breast cancers. I think it's just managing like your chemotherapy toxicity, not really more of a. Next slide, please.
Dr. Amit, if you can just conclude.
Yeah, I'm just concluding too. So when would you stop the chemotherapy, Dr. Akash? In a recurrent setting, how many? 6 cycles continue chemotherapy?
6 cycles or untoward toxicity, and then maintenance.
So the recommendation is, if you are giving platinum, it is 6 cycles. If it is not, you're not giving platinum, then you can continue till benefit is there. Let's go on to the last slide, please. Go ahead, please. Go ahead. Yes. Last one, follow-up. Yeah. So follow-up visit. So CA-125, just quick word from all the 3 medical oncologists and our surgical oncologists. How frequently would you call? So suppose a recurrent patient, she has been disease-free now. How frequently would you call, and what is your choice of imaging, and how frequently would you monitor the CA-125? One word from all the panelists, and then we conclude.
I would call the patient every 3 months, and not necessary that I'll do the imaging every time. Only if the CA-125 increases, then only we should try to keep her drug-free interval as long as possible.
Dr. Akash?
If not on maintenance, 3 monthly with CA-125.
Dr. Sampada? Dr. Gaurav Gupta, you can take that.
So usually 3 months is the interval, and CA-125, and I usually prefer a USG abdomen with that.
Yes. Dr. Sarnakat, CT scan or PET scans, how frequently would you do?
So see, CA-125 every 3 monthly, and USG and CT abdo-pelvis maybe alternately every 3 monthly.
Every 3 months.
Yeah.
So no PET scans again? CT is sufficient for everyone?
Yeah.
So I guess the panel is of the conclusion that PET scans are not to be done and CT is good enough. As Dr. Rohit had said, CT is good enough. Okay, thank you so much for this, and it's been a night interacting with you. Thank you so much, and thanks to organizers for the lovely meeting.
Thanks, Dr.
Thank you. Thanks.
Thank you, Dr. Amit. And that was quick and comprehensive. And I think as far as HIPEC is concerned, it was always about cytoreduction than the heat-sensitive chemotherapy. And sadly, I don't think we can take questions. So we move on to the next session.
We also have one new choice now, that HIPEC, which use the aerosol this thing of preparation interperitoneal, but I don't think they're available. I think in Manipal they're doing it. I don't know. I mean, how it fares the long run.
That is mainly for in palliative setting.
Yeah.
So thank you. Yeah. So we move on to the next one. And would you like to call the speakers, Doctor?
Yes.
Would you like to call Dr. Anita Ramesh?
Our next topic is a debate, the role of bevacizumab in gynecological malignancies, hope or hype. And Professor Anita Ramesh will be talking for the topic, and Dr. Bhavesh Poladia will be calling it against it. So I would like Dr. Anita Ramesh to start their presentation.
A very good evening to everybody. I hope everybody can see me and hear me. Oh, okay. Yes. Thank you. Thank you. So nice to be on a digital platform. And let's see how we can place these drugs and bring our patients out. Yes, warm greetings. Stay safe, stay connected during this pandemic from the university. And so, as you know, when the tumor burden increases, there is a chance when after the treatment, the patient may get into remission. But there are some cells which are clinically dormant, and that may escape. There can be an angiogenic dormancy, there can be immunologic dormancy, and that's what comes back, and then you get the relapses. And as of now, today we are going to talk about in one size does not fit all. It's a precision medicine, and let's go with what the patient needs. So, and each patient benefits, and we need to give the best to them. So as of today, cancer is based on an integrated approach of several biomarkers, proteins, imaging, and molecules. Many of us have lost amongst us, many of the celebrities, many of them have died for the common cancer, which still predominates in India, more in the rural area. So this is one of the patient who had a metastatic recurrent cervical cancer. And I questioned my opponent as well as everybody. Would you not give her the chance to live? Would you not give her the best medicines, a combination of taxons, platinum, and bevacizumab? She had extensive meds. So what is the evidence? Why should we use this drug? Yes, we have the GOG 240, which looked into the stage 4 recurrent metastatic cervical cancer, had the 3 arms where topotecan, bevacizumab, all were integrated. And if you see the p-value of the chemotherapy and the bevacizumab, the curves separate at 12 years and with a significant p-value of 0.002. Overall survival benefit, even the p-value was significant when chemo and bevacizumab was used. And in combination, even it was p0.3 with the 2 curves separating at least 1 year, maybe 1.5 years as per the graph, you have a definite progression-free survival and overall survival benefit. A meta-analysis followed to see whether bevacizumab does something in cervical cancer. Yes, combination with taxane, topotecan, or a platinum, there is prolongation overall survival once you add the bevacizumab, and also shows the highest efficacy with the taxanes and the topotecans. So it's quite effective in cervical cancer, promising results, and not much documented side effects. So there's an expanding role of bevacizumab. It's not a hype, it's a hope. Patients are living. We are able to give them life for more than 12 to 15 months. And that's what's important, because in a morning of tomorrow morning, you will have somebody who is saying, do something for me. So what's next? Yes, you can give bevacizumab. Yes, if it fails, we have other drugs as checkpoint inhibitors. So that's the rationale. Give it at the right time. Try to prolong the life and see what best you can do. So that's bevacizumab now falls into the past, present, and future of the gynecological malignancies. It's got into approval with recurrent, persistent, metastatic cervical cancer. Yes, this drug is there. So that's one chapter. Let's look into the other ovarian tumors. Yeah, Monisha Koirala and others, many have survived, many have left us. Yes, it's a dreaded disease. All of us get patients who come meet just that incremental gain which is needed. And that's what we are meeting tonight to talk upon. Any groundbreaking trial, any drug that we can give. We heard about PARP inhibitors. Also, there is some role of the immunological agents. But before that, a patient 52, it's a middle age as on today, cytology positive with ascitic fluid, massive mass. How do you proceed? I'm sure the surgeons will not take them. Yes, chemotherapy is the sheet anchor. We need to do an interval debulking surgery. And the drug, patient will ask you what you want. Yes, we have a hope for you that bevacizumab is now approved in inoperable stage 3, suboptimally debulked stage 3, stage 3, 4 with ascites, stage 4 disease, and any new diagnosed patient recurrent metastatic. Ascites is one of the very good marker, or if you see both progression-free and overall survival, if you see the chart, significant improvement in the progression-free and overall survival with a significant p-value. Icon 7, patient with high risks of progression, all the curves are separating. So in high risks, stage 4, inoperable, suboptimally debulked, that is, we heard the last discussion, if you can't operate, what do you do? Yes, we have a drug. We can come out of the OT and say, yes, we can still do something for you, which will help. What happens to the quality of life? That's all. It's almost the same small increase. Just see the two lines, both are parallel. Just by adding an increasing drug, bevacizumab, and giving its maintenance does not mean you're increasing the toxicity to any one of them. Yes, it can be continued for a long time. Be very careful about the hypertension, proteinuria. Judge your patient. Alternately, you will be on the safe track. Many patients present like this, huge tumor, platinum sensitive relapses. Okay, again, bevacizumab is the drug of choice. FDA has approved in a recurrent setting by the phase 3 OCEAN trial. So both in recurrent platinum sensitive is a standard of care. What happens in platinum resistant when you fail less than 6 months? We have many patients. Yes, we have something to give to them as well. So apart from, you may not be able to use the platinum, but you can use a taxane. You can use liposomal doxorubicin. You can give topotecan and add the bevacizumab. It gives you a longer survival. There are lots of references which tells us. So icon 7, we'll quickly go through OCEAN, updated progression-free survival, even the final OS data of the GOG protocol 2.4, which was presented at the ESMO conference, all points to that. Yes, we have something to give, and there is hope for these patients who does relapse and not doing very well. Aurelia is another study which looked into recurrent things. My component may say, why do you add an expensive drug? Bevacizumab may not be as expensive as it was before. We have generics coming in. Company has lot of, the assistance program. We write to them, we get the patient the best thing. Side effects are not tolerable. Be careful with the hypertension and proteinuria. That's all, and bleeding. And if there is some obstruction, don't use the drug. Otherwise, you can safely use them. So the big role of angiogenesis in gynecological malignancies, how we can use this drug. Let's look into the guidelines. Say NCCN, say ESMO, all the guidelines has bevacizumab in upfront, both in sensitive, intermediate, metastatic, and recurrent scenario. At all levels, bevacizumab forms a backbone in this NCCN. ESMO guidelines from 2018, bevacizumab has been approved. So once it is, these guidelines have looked into cost benefit effect, and it's not that the expense is more, but the benefit we get, but there's a cost effective approach, and almost all the guidelines have incorporated bevacizumab in these malignancies. There are a lot of review of literature which all points out that yes, these are the studies and how it has improved our patient. Because you remember, the patient sits next to you, will be asking few months to be alive. Yes, and we are here, what we can do, how we can improve, because those couple of months, it may be 6 months or 12 months, is very important for her. So it's leaving a mark on the overall survival in ovarian cancer in all aspects. If you see this profile, all the trial outcomes, Otilia GOG 218, and in a stage 3 with a side state GOG 218 has shown the improvement. And so, yes, we can take them for some time, and then the immunotherapy and the PARP inhibitors can be used upfront. Let's not forget about the last malignancy, which is the endometrial cancer. Now, endometrial cancer has been divided by the molecular subtyping, and you can separate out tumors which need the immunotherapy. You do separate out the tumors which are high grade. And yes, there is also a lot of emerging data once you do the molecular profiling of the endometrial cancer and the prognostic significance. And there's a group of patients who might relapse and might need bevacizumab as a maintenance in a relapsed endometrial carcinoma setting, provided you choose them properly. And that's how I want to conclude today. Leave the mic to my opponent to take it forward. I'm sure by seeing the data, and in your practice, you must be also doing, and something which is doable, cost effective, and we can convince the patient and bring smile to these gynecological cancer patients who is at your outpatients seeking for help from you. Thank you.
Thank you, Dr. Anita. Now, the rebuttal.
Can you just share my slides? Yeah, sure. So it is always difficult to debate with Anita ma'am, but I'll try my best. So here the role of bevacizumab in gynec malignancy, we have to just decide whether it is hope or hype. I'll be from the hype side. Probably it's a weak side in a medical oncology conference, but let me see whether I can convince you or not. Next slide, please. So I have to talk on why bevacizumab is not always the drug of choice in all type of patients. So this is very, very important, and I'll just change the sequence. Madam started with cervical, went to ovary, and finally to endometrium. I will start with ovary because this is where I find more usage of bevacizumab. Next slide, please. So let's start with the ovarian cancer, and we have multiple options starting from cisplatin, carboplatin, paclitaxel, topotecan, liposomal doxorubicin, gemcitabine, bevacizumab, olaparib, pregabalin, and so on and so forth. So basically, ovarian cancer is not a sprint; it is a marathon. So we have to consider one after the other agent, and each agent will have its own role. Not only giving the agent, but how do you give the agent? Like intraperitoneally, neoadjuvant setting, you give it as dose dense, addition of anti-angiogenic therapy, PARP inhibitors, and immunotherapy recently. So there are so many options available for ovarian cancer. So does only bevacizumab is the most accepted frontline player? Let's see. Next slide, please. So these are a few of the early phase trials of bevacizumab where they have concentrated on the overall response rate and PFS. As you can see in all the three trials, the overall response rate is somewhere around 15 to 25%, and 6-month PFS somewhere around 25 to 56%. There is a small fistula and GI perforations are included. This PFS is oriented that trials only for PFS or ORR. They are not oriented towards OS or any other benefit. Go to the next slide, please. So this is what is routinely our practice in ovarian cancer following GOG 218 or ICON 7. This is a typical example of adjuvant. I am not even discussing bevacizumab in neoadjuvant because there is no hard data at all. There is no phase 3 randomized control trial to use bevacizumab in neoadjuvant setting. So, and I'll prove that bevacizumab in phase phase 3 GOG 218 and ICON, you see there is a PFS advantage again only for couple of months, but when it comes to OS, there is no significant role. In both there were 3 arms, and we can see in GOG 218, and there were 2 arms in ICON 7. So none of them have shown a significant OS benefit, and probably I don't think PFS is only thing what you can go for bevacizumab. Next slide, please. So coming to the next phase of ovarian cancer, that is recurrent setting, both in sensitive as well as resistant pattern, following the famous trial of GOG 213 Oceans for sensitive ovarian cancers and Aurelia for the resistant cancer. So again, you see there is again only PFS advantage by a couple of months, where if you see the OS numerically better, but none of them are showing a significant OS survival. Next slide, please. So I'll just show you this graph of ICON 7. As you can see, the graphs are almost overlapping each other. There is hardly any difference you can see, and there is that's what I would like you to concentrate on. The final OS, there was hardly any difference with no significant p-value, and HR crossing unity. Go to the next slide, please. And MRCC final OS subgroup. So they were just trying to find out, okay, if we cannot have OS in overall, let us find out some subgroup where we can, offer or we can push bevacizumab. So let's see what happened. So stage 1, stage 2, stage 3, everything failed, nothing works. So bevacizumab has not shown a major improvement in ICON 7. Coming to stage 4, again, numerically, it is very nice. You can see almost a difference of 10 months in overall survival. With an HR of 0.76, again it is crossing unity. So I'm a little skeptical, but probably if I have to use, probably stage 4 is the only subgroup. And those patients who are non-operable, again there's a stark difference of median overall survival of 20 months. But again it is crossing the unity being HR of 0.52. Probably this is the reason where we have very small number of patients, 30 and 182 in non-operable and stage 4 respectively. So there is a significant benefit only in a very, very selective patient of stage 4 and non-operable patient. Otherwise, none of them get any benefit of OS. Next slide, please. So this is again GOG 218. You can see the OS at the time of primary PFS analysis. initially there was no significant difference at all. Go to the next slide, please. So what they again like icon 7, they try to see whether there is any subset analysis which is going to help them to just promote bevacizumab. And there again you can see this multiple graphs and multiple lines. Probably only stage 4 is the one where there was a 10 months overall improvement. And stage 4, when we use and we get an OS benefit in the upfront setting, mind you that this is a continuous use of bevacizumab. So it is not very easy to handle, and not easy for handle for the patient especially, both financially as well as toxicity wise. So now question arises about the duration and what is the optimal dose of bevacizumab which is used. Because I am very sure that every one of us are using different doses. Some are using 5, some are using 7.5, some are using 15. I'll just see in the next slide. Next slide, please. So the treatment duration and dose. So if we follow the GOG 218, we have to give 22 cycles with 15 milligram per kg. Mind you, the dose is 15 milligram per kg over here. And if we follow the icon 7, there is 18 cycles to be given with 7.5 milligram per kg. But even after giving all this in adjuvant setting, in recurrent setting, you hardly have any OS data. So, OS is not very good. So that should we put so much money, so much toxicity, and so much decrease in the quality of life for the patient? Still open for discussion regarding the dosing and duration, because I'm sure everybody uses their own way. Next slide, please. Coming to the safety profile, again, very important, because if you compare all these three groups, whether chemotherapy alone, chemo with beva concurrent, and chemo beva followed by maintenance of bevacizumab, you can see there are so many GI events. Hypertension, definitely, if you don't keep a watch, they are going to come with complications. Pain, neutropenia, both are worse in the maintenance phase. Wound disruptions are also there. So there is definitely increased toxicity while using bevacizumab, mainly the GI, the hypertension, neutropenia, and few more. Next slide, please. So enough of ovarian cancer. Now let's go to the cervical cancer, with which what Madam started, and Madam was very happy about it. So if we see this NCCN 2021, there are multiple options which are there where we can use different kinds of therapy for such patients, and we can probably not use bevacizumab at all. Let's go to the next slide. So this is the famous trial GOG 240, which has led to the approval of bevacizumab in stage 4 cancer. Everybody of us knows how the design schema was there. Go to the next slide, please. So yes, I agree there is a survival benefit with bevacizumab, but what about toxicity, quality of life, and cost? So do you think in a country of India, how many eligible patients are going to afford that kind of a therapy? Go to the next slide, please. So the treatment exposure and specific adverse events, we cannot just overrule it. You see the GI fistula, GU fistula, hypertension, neutropenia, thromboembolism, especially when there is a pelvic malignancy like cervix cancer and recurrent and metastatic setting, it is very difficult to manage such patients. They'll often come with fistulas between the GI tract, the GU tract, the gynec tract, and it all becomes a mess. They'll come with hemorrhage, and this becomes a very difficult situation to handle later. Go to the next slide, please. Again, coming to the quality of life, you see the mean FACT CX TOI, and we see that see in the graph, the blue graph is the one which is having bevacizumab, and the red one is only chemo alone, and it is consistently higher than the combination of chemo plus bevacizumab. So patients receiving bevacizumab have reported 1.2 point lower on average. That's what is the difference in quality of life. Definitely, it is not same as water. Go to the next slide, please. So coming to the cost, so from this JGO Journal of Global Oncology, they have addressed this thing, which is very relevant to our country, because more than 85% of cervical cancers occur in lower and middle income like our country, and mortality rate is 3 times higher than in developed countries. So is it really affordable to? Affordability is still an issue. You have to ponder on it. I think yes, it's a big issue. Next slide, please. So lastly, coming to the endometrial cancer, I still thinking, is it easy to go against bevacizumab or not? and you can see that all these trials are phase 2 trial. There is no hard phase 3 randomized controlled trial to prove that, okay, use of bevacizumab is mandatory or it has shown some improvement. So you can see this all response rates and PFS, these are all there, but it is not translating into a major benefit for endometrial cancer patients. Go to the next slide, please. So this all randomized study with bevacizumab. These are the two I have picked up, and you can see again the PFS is okay, good looking, 4-5 months of difference. Median OS again showing a good difference, but what about HR? It is 0.65 and crossing the unity. Again, it is not a significant one. So this is a special comment. Okay, we can miss that. Conclusion. So of course there is a survival benefit with bevacizumab. I will not say it is absolutely out of the window, but it is very, very specific. Mainly you have to speak with your patient to say that PFS is the only benefit what you are looking for. OS in very, very specific subgroup. OS definitely yes in cervical cancer. Some PFS benefit endometrial cancer, yes. But again, see, this comes with a lot of problems, toxicity, GI perforation, wound which are not healing, serious bleeding, hypertension. If you just don't do monitoring, they are going to come with some stroke or infarct or something like that. Some kidney problems, infusion related reaction, less, but it is still exists. Severe stroke or heart problems, nervous system and vision problems, you just can't ignore all of them. And definitely last but not the least, cost in developing countries like India, very, very big and huge burden. So I wonder that even 10% of our eligible patients are actually getting bevacizumab. That was, I think, my last slide. Thank you.
Thank you so much. And right, thank you so much. And would Dr. Ramesh have to have in a couple of minutes? Does she want to rebut anything that he has said? Then we conclude.
Yeah, thank you, sir. Thank you, Dr. Bhabesh. We are all from Tamil Nadu. So yes, you have pointed out well, but yes, in oncology, we know medical oncology, finance also plays a major role. If you keep the finances away, and if it is scientific, yes, bevacizumab has a role. But I also agree with you, finances are important. Now, this drug also got approval in many of the government schemes. Many of the government hospitals are giving it free of cost, and the prices have come down because of many generic companies are over here. And also, as the competition is high, many of them are giving free many offers to the patient assistance program. So that makes it more accessible to this drug. Side effects are there, like all chemotherapy has side effects. If you say that side effects are there, then we medical oncologists have to stop practicing. But we should know how to manage this. And bevacizumab is a quite reasonably good manageable drug, and which can be given up to progression or any further toxicity. So these are the, and quality of life, and I can also ask the same question to you. How many patients in your practice have lost their quality of life taking bevacizumab? Rather, it is one of the safer drugs to be given. So on this point, I just want to conclude, yes, there are some points for discussion, but definitely it is a hope. And we didn't have drugs, okay, to take them forward. Now we have something to tell them, yes, we can give you something.
Thank you, Dr. Ramesh, and very interesting presentations from both of you. The jury is still out. Thank you, Dr. Bharat Chavan, an excellent meeting, and thank you for giving me this opportunity to be here. It was wonderful connecting with all of you and a lot of good information. Thank you so much.
Before it ends, Dr. Anita, so would you say that the take-home message is stage 4 disease or at least as a would not wanted in a neoadjuvant setting because of the so many complications here? I mean, they have described and it is there. So what would be the ultimate take-home message? You would say, leave aside the side effects.
Yeah, so
for the advantage of maybe 4 to 5 months of survival benefit, which is, quite statistically not that significant compared to the cost, but still, yes, if some people want, yes, we can give.
Yeah, 6 months to 12 months is most of these studies which showed a progression-free survival. Yes, I would conclude saying that bevacizumab is a drug which can be used in recurrent metastatic cervical cancer, and after the chemotherapy is over, continue at maintenance till progression or till any side effects develop. For ovarian cancer, yes, platinum sensitive, platinum resistant. It's the drug for continuation of continue as maintenance. Also, you can give upfront in stage 4 with patient with ascites, inoperable tumors, or tumors with suboptimally debulked. Again, continue it till progression. Endometrial cancer, it is finding its role, but definitely we don't have much drugs in a metastatic recurrent setting. Bevacizumab can be added to the chemo armamentarium.
Thank you. Thank you. Thank you so much. So do we wind up now?
Yes.
Yeah. So thank you, Bharat, all over again. And
Nice to see you.
excellent evening. Thank you so much.
Before we end, I just want to make an announcement that due to the overwhelming response, our round 2 is also open for all the participants. Today we have around 65 participants in the quiz and 154 logins in the delegates category. And with such a esteemed faculty and such a good interaction and nice debates and awesome presentations, I think our conference is going in a right direction. So thanks to all of you, Nagaraj sir, Anita ma'am, Bhavesh sir, and Bhavesh Poladia, my colleague, and Rajiv sir. It was really an awesome meeting. Thank you. We'll meet tomorrow again. Thank you.
Thank you, Bharat Jawan. Thank you, Nagaraj sir, my chairperson also. Thank you, everyone.
Thank you.